In this section, we'll be discussing on a very practical topic, that is on oxygen delivery devices. So there are a lot of misconceptions, myths, and misunderstandings about this particular topic because we have very poor knowledge on how these devices are going to work. So if you don't have a good knowledge on how these devices are going to work and where to utilize these devices, ultimately it's the patient who's going to get affected and it's going to be detrimental for them only. So it's very important to understand this. At the same time, there are a lot of potential entrance exam questions also, which I'll be discussing simultaneously in this particular video. So first, the moment we talk about the oxygen delivery devices, the thing that comes into mind and the thing that will be given in the books is about the low flow devices and the high flow devices. So what do you mean by low flow devices and what do you mean by the high flow devices? Remember, for example, whenever I have my own breathing, like that is what we refer to as a minute ventilation. Minute ventilation is a function of tidal volume as well as respiratory rate. So let me write it. Minute ventilation is a function of tidal volume and respiratory rate. We have discussed this extensively in the physiology and the respiratory failure section itself. So if a device is able to satisfy my minute ventilation by giving a gas flow completely, that is equating my minute ventilation or more than that, so that is what we refer to as a high flow device. Suppose if a device will not be able to satisfy my minute ventilatory needs, so that will be a low flow device. For example, during dyspnea, my minute ventilation is going to increase multifold. Like when I'm breathing at 8 liters per minute, normally, during dyspnea, it might become up to even 25 liters per minute. Usually the maximum range is around 25 to 30 liters, but it will not go beyond that, but it can go up to that extent also, my minute ventilation, because during dyspnea, my depth, that is the tidal volume and the rate of respiration, all these things are going to increase. So whether a device will be able to provide this entire minute ventilation by its own gas flow or not is the question. So that is the one that differentiates a low flow device versus a high flow device. Which means, what do you mean by a low flow device and what do you mean by a high flow device? Remember, a low flow device cannot satisfy the minute ventilatory demands of the patient. Its gas flow will be always lesser than its O2, or the gas flow will be always lesser than the minute ventilation or the peak inspiratory flow rate of the patient. Very important. Whereas a high flow device can satisfy the minute ventilatory demands of the patient, which means its oxygen and gas flow will always be more than the minute ventilatory demands of the patient or the peak inspiratory flow rate. Very important concept. Number one. So what are the examples for this? The best example for this will be a simple nasal cannula. You would have seen this nasal prongs in a lot of areas in your hospital, in the wards, in the emergencies, where the patient will be lying with the nasal prong. That will be simply just connected to the bubble humidifier, isn't it? You would have seen. So that small thing that's bubbling where oxygen is connected, that's what we call a bubble humidifier. From there, you just get that tube and that connects to the nose. This is simple nasal cannula. At the same time, you have a counterpart that's called a simple face mask. Similar arrangement, but instead of the prongs, you'll have a mask. That's it. So this is a simple face mask, otherwise referred to as a Hudson mask. These are characteristic examples of a low flow device. Remember, again, I'm telling you, it's not the cannula or it's not the mask that will tell you whether it's a low flow or a high flow device. It's the arrangement that you make that will determine whether it's a low flow or a high flow device. The same nasal cannula, I can connect it to a different set of arrangement and make it a high flow device. That's what we refer to as a high flow nasal cannula, but with a lot of sophisticated instruments and arrangements, which I'll be discussing in some time, because this high flow nasal cannula is a very important emerging topic and that has plentiful of applications in the current era, and it's improving actually with day by day, and this is a very important potential question. And obviously it's not complete if I don't tell Venturi mask. This is not the end. There are a lot of devices which can act as low flow. There are a lot of devices which can act as high flow, like your tracheal masks, then T-pieces. All these things are also examples of high flow devices only. But there are some devices which can act as low flow as well as high flow. For example, your non-rebreather mask, sometimes it can be used as low flow, sometimes it can be used as high flow device. It all depends. So it's not the exact mission that's going to determine whether it's low flow or high flow. It's the arrangement and the back-end planning that you do that you can make a device as a low flow or a high flow device. The understanding is very simple. Low flow device will have a gas flow that will be lesser than the minute ventilator needs of the patient, and high flow device the one that provides more gas flow than the minute ventilator demands of the patient. That's it. So this is the basic understanding. So let us first compare and contrast what is the difference between a simple nasal cannula and a high flow nasal cannula. Not here, just in the low flow and high flow vision, what will be the difference. Now what this low flow device are going to do? Let us take a simple nasal cannula, and I'm going to plot time over here, and probably I can plot the volume, that is during the minute ventilation. I'm going to plot here. So the minute ventilation, initially let us assume the patient is having probably 10 liters, or let us tell 6 liters initially, 6 liters per minute. So first I am breathing normally. So minute ventilation will be equal to tidal volume into respiratory rate. Let us assume I am the one who is breathing now. So it is 500 ml at rate of 12 per minute. So I can write 6 liters, 6000 ml. So suddenly I am getting dyspneic now. Early stages of dyspnea, probably if somebody leaves me just like that, I'll go into a full-blown respiratory failure. But now only I'm starting to get respiratory failure. So let us assume the tidal volume remains the same, even though tidal volume will increase. But let us assume in this example, tidal volume remains the same, 500, but my respiratory rate has increased to 20. So now it will be 10,000 ml, that is 10 liters, right? So now suddenly I'm getting dyspneic. Now I got my minute ventilator needs, that is 10 liters per minute. Now let me assume I'm receiving a nasal cannula oxygen flow, which is happening at the rate of 4 liters per minute. 4 liters per minute. So remember, first of all, my basal demand itself is 6 liters per minute. During dyspnea, now it is 10 liters per minute. Now you can understand the fact that this will be the nasal cannula flow, which means only this part of my minute ventilation will be satisfied by my nasal cannula. The remaining part, I have to use the atmospheric air only. There is no option. I have to take, because I cannot live without satisfying my minute ventilation. That is really important. So that I cannot live with that 4 liters. I need that 6 liters baseline and this 10 liters at dyspneic period, and in this example at least. So this extra, for example, only 4 liters is coming through the nasal cannula, and this extra 2 liters I have to take from the atmosphere only. There is no other option. Similarly here, I need 10 liters now. So this extra 6 liters I have to take from atmospheric air only. Which means what you're essentially seeing here is you're diluting up. Obviously, the nasal cannula that is giving this 4 liters per minute oxygen will contain 100% oxygen, which means FiO2 is equal to 100 or FiO2 is equal to 1. Clear? So it is 100% oxygen. But you are actually contaminating this 100% oxygen with atmospheric air because of your minute ventilator needs. Here I am contaminating it only 2 liters at baseline. But when I get dyspneic, I am contaminating with 6 liters of atmospheric air. So which means the more and more you contaminate with the atmospheric air, the more and more you dilute with the atmospheric air, more and more the FiO2 is going to drop. The deliverable FiO2 will decrease. So the same 4 liters per minute nasal cannula oxygen at baseline, it will provide a different FiO2. When the patient is dyspneic, because of heavier contamination, heavier dilution from the atmospheric air, it will produce a far lesser FiO2. It will deliver a far lesser FiO2. Suppose if my dyspnea increases and my minute ventilator demands increases to 20 liters. For example, now I am taking now 1000 ml because my depth of breathing has increased and 20 per minute respiratory rate. Now my minute ventilator demands has become 20 liters. At this 20 liters, if I'm still giving only 4 liters per minute, means I'm going to dilute with the atmospheric air to approximately 16 liters. So that's going to drop the FiO2 even more. The FiO2 delivered by this device will be dependent on the minute ventilator demands of the patient. Point number 1 taken. So which means this can also be referred to as something called a variable performance devices. These are variable performance devices, which means the FiO2 will be completely variable and it will be completely dependent on minute ventilation. The first thing that will be dependent on the minute ventilation, that is the tidal volume and the respiratory rate. Definitely, no doubt about that. and probably it might be affected by other entities like mask seal. Suppose if you are using a face mask, it will be dependent on the mask seal. If the mask seal is not good, atmospheric air will again come from the sides of the mask and it will dilute the oxygen that is flowing into the mask. So it depends on the mask seal also. At the same time, with respect to the nasal prongs, it depends on mouth breathing also. But in face mask, it doesn't matter. But with respect to the nasal prongs, how much mouth breathe you do. So that also is going to dilute the FiO2 that you are going to get from the particular device. So to avoid all this, we have a high flow device. What high flow device does is cool and relatively simple. Let us assume the same patient initially is having 6 liters of minute ventilation, and later on he is getting dyspneic, where he now needs 10 liters per minute of minute ventilation. But this high flow devices deliver oxygen in such a way, or deliver gases in such a way, that your delivered oxygen or gas by this particular device is always higher than the minute ventilation. That means, for example, if it provides at 60 liters per minute, you can see even if the patient goes for severe dyspnea and he breathes at 30 liters per minute of minute ventilation, you can see the entire minute ventilation can be delivered by this device at a particular FiO2, which means it will be delivering an accurate amount of FiO2. That's the idea. Fine. So now I can tell these devices are fixed performance devices, which means they deliver a very accurate amount of FiO2. Clear? It doesn't depend on the minute ventilation or tidal volume or respiratory rate, because they are providing such a high flow. So that's the reason. So these are the basic understanding about a low flow versus a high flow device. Now with this example, let us move on to what are the devices that we are going to see commonly in the OPD. So oxygen delivery systems are divided into oxygen delivery systems that are seen in the hospital and oxygen delivery systems that are seen in the home, isn't it? You can use long-term oxygen therapy also. So how can you classify oxygen delivery systems that are present in the hospital? First one is the blow-by oxygen. I'll be discussing in some time. Second one is the nasal cannula system. Second type you can see very commonly in the hospital. Third one is the face mask system. Face masks and face tents. Face masks and tents are very rare, but face masks are very common. Different types of face masks are there, which we are going to discuss. And next, we have these kind of enclosure systems, where we have oxygen tent and oxygen hood. We'll discuss about that also, usually commonly used in infants. And finally, you have this kind of ventilation bags. So under the 5 headings, we are going to discuss blow-by, nasal cannula, masks, enclosure systems, ventilation bags. Ventilation bags has 2 types, self-inflation and flow inflation. Again, we are going to discuss in detail. And then we have this kind of miscellaneous devices also, which are very rarely and sparingly used. One is the Venturi mask. Again, we have a lot of discussion left on Venturi mask. And we have this kind of tracheal mask also. This is like a simple face mask, but it's suited for trachea, kept over the trachea in patient with tracheostomy. These are called as trach masks or tracheal masks. Then you have TPs, very commonly used, this one, especially when you are weaning from a ventilator, very common, TPs. Then we are going to see some special types like hyperbaric oxygen therapy. And finally, we are going to discuss on the ways to give LTOT in patients with chronic lung disease, long-term oxygen therapy, how to deliver this in a patient who is sitting in home. This is for home oxygen delivery. Clear? Fine. So this will be the essence of this particular topic. So let us begin with the blow-by. So what do you mean by a blow-by? The simple way to understand a blow-by is when you just connect the oxygen tubing to the oxygen port, and you just take the tubing, don't connect with the nasal prong or don't connect with the face mask, just blow over the patient's face. Very unreliable method, but still if the patient is extremely agitated, especially if it's an infant or a toddler, they are definitely not going to listen to you. Even if you put a mask or a prong, they are going to throw it off. They'll be uncooperative. Similarly, if an adult who is extremely uncooperative, but remember this is only a transient method or a temporary method of delivering oxygen to the patient. So it cannot be a definitive method. You need to find out definitive methods ASAP. But this can be used as a temporary measure. So in this group of people, especially particularly this infant and toddlers, you can use blow-by as a little bit temporizing oxygen delivery measure. Clear? But you have to search for a definitive measure in some time. It's not enough. So there are a lot of ways to achieve this blow-by. So first of all, to achieve this blow-by, you need a reservoir first. Reservoir is mandatory. That's a very important component of a blow-by. So this reservoir can be made in adults. You can make it with the face mask itself. The face mask, that cup-shaped face mask itself, act as a reservoir for oxygen. But in children, again, they will throw the face mask. So you're not actually, again, remember, you're not putting the face mask on. You're just keeping the face mask nearby so that the oxygen will be blowing into the patient's face. But in children, some innovative techniques you can do, especially when you're in the field, in emergency, when you're going as a paramedical, going to the home to pick up a child. So in those conditions, if the child is unaccepting to all these things, then you can use things like paper cups or styrofoams. Styrofoams are nothing but your thermocol things where you used to eat pani puri in that. So that's a styrofoam, isn't it? So you can use that styrofoam and put an opening hole in that and connect the oxygen tubing and keep near the patient's face. So that's what is being done in this child. You can see this is the oxygen tube that is coming here, where there is a hole in, they have put a hole in the cup, paper cup, and just they are blowing out to the child's face. So this is an oxygen blow-by. And you can see this is a plastic cup here, where there is a tube of oxygen that is coming inside and the oxygen tubing is inside through an opening. And now this acts as a reservoir, this plastic cup, and this is blowing into the child's face. This is a simple way of giving a blow-by oxygen. You need a reservoir for sure. Clear? In worst case scenarios, even reservoir is also not available, just you can blow over the patient's face. Very, very unreliable method, but sometimes helps in extreme emergencies. It can deliver FiO2 to less than 30% only, because you are just blowing over the patient's face. How much is going into the patient, how much is going into the atmosphere, God only knows. You don't know. FiO2 delivered is usually very unreliable, less than 30%. And remember, O2 flows must be at least more than 10 liters per minute. Do not use oxygen flows to less than 10 liters per minute. Again, it's not good. Deliver oxygen flows at more than 10 liters per minute. And the most important question here will be, there are two ventilation bags are there. One is called a self-inflation bag. Second one is the flow inflation bag. We have a discussion left about these two devices. What do you mean by this self-inflation bags? Immediately we'll tell Ambu. No, Ambu is just a company. You have a lot of other self-inflation bags like Lerdal bags are there. Then Mayo, Signer. So many self-inflation bag companies are there. Ambu is just one among the companies, but it became very famous. That's all. So which one can provide a reliable blow-by? Surprisingly, Ambu cannot provide a reliable blow-by. The self-inflation bags cannot provide a reliable blow-by because they have this one-way valves which protect against rebreathing. That itself will become an enemy for this blow-by. You cannot do that. But flow inflation bags, yes, very important question, 2 times asked in PG already. Self-inflation bags like Ambu cannot provide a reliable blow-by oxygen, whereas flow inflation bags, yes, they can deliver a reliable blow-by oxygen. If you have used these devices, definitely you will know this. Otherwise, it's very impossible. You go to the operation theater, this slow inflation bags are also called as anesthetic bags. You can go and check with yourself. So how this can be used as a blow-by oxygen. Fine. So this is all about the blow-by. So then we are moving on to the nasal cannula section. So nasal cannula, we have 2 types. One is called a simple nasal cannula. So this is an example of a simple nasal cannula, otherwise referred to as a low flow nasal cannula, where it has no complex arrangements, just connect to the oxygen source and put it into the patient's nose. That's it, nasal prongs. And very importantly, whatever may be the cannula, whether it's a low flow or a high flow, the nasal prong size, the prong size should be less than half of the diameter of the nostril. The diameter of the nasal prong should be less than half of the nostril diameter. Very, very important. It should not be completely filling the nose. So this is the mandatory criteria that has to be followed. Clear? So what is the amount of FiO2 that it can deliver? Remember, usually the FiO2 that it can deliver is only up to like 24 to 35%. That's what I believe. This much only they can deliver. But your Indian textbooks will give some numbers, like for example, 1 liter can provide 24%, 2 liters can provide 28%, 3 liters can provide 32%, 4 liters can provide 36%, 5 liters can provide 40%, and 6 liters can provide 44%. So I can write a variable cutoff of 24 to 48% according to the Indian textbooks. Both are correct. Nothing is wrong. But remember, being a low flow device, it will be a variable performance. It's very, very important. FiO2 is unreliable, and it's a very, very important disadvantage of this device also. Because it's a low flow device, the FiO2 will be unreliable. The FiO2 will be dependent on the minute ventilation of the patient, which is in turn dependent on the tidal volume of the respiratory rate, and it's also dependent on the extent of mouth breathing from the patient. So many factors will tell you the oxygen delivery by this particular device, FiO2 delivery. So I don't really trust that it produces a fixed FiO2 like this. It itself is wrong in the first place in the context of a low flow device. It's going to deliver a variable FiO2. Just tell a range 24 to 44 or 24 to 35%. That's it. You cannot use beyond 6 liters because they can't tolerate. You cannot deliver through the tubing. Like you need a better tubing and you need a larger bore tubing to deliver higher flows. This nasal tube is this much only, 6 liters. It cannot go beyond that. Even though some sources tell with some new tubings are coming which can go up to 10 to 15 liters of oxygen you can deliver, but still the FiO2 will not change that much. Clear? With this kind of prongs and with this kind of tubing, it still will be only 24 to 44 or 24 to 35%. Fine. So this is all about the simple nasal cannula. It's a low flow device. That's all. Second disadvantage you're going to get is the side effect, that is your dryness. You might ask me one question, sir, how is it possible? I am seeing a humidifying jar over there where that's called a bubble humidifier, isn't it? You would have seen in the what's in the corner. So where its oxygen is always bubbling from that. So whether it humidifies good or not, answer is definitely no. It's a very bad humidifier. But still we are using it because we have the one principle in the hospital called something is better than nothing. So it just does some humidification but not a good humidification. If you're using for 6 to 8 hours, this nasal prongs, you're going to end up with dryness. Sometimes it may result in bleeding also. So you have to be careful. Dryness is one of the very important complications. Fine. So with this, we are moving on to the high flow nasal cannula. Trust me, this will be your question, especially when you're going to your institute exams. This is a very, very important upcoming area. It's a definite question in your institute exams. High flow nasal cannula. So what this high flow nasal cannula does, it needs some special devices. For example, the tubing itself should be very special. It should have a corrugated tube. Not only for high flow nasal cannula, any high flow devices. We have talked about a lot of high flow devices. All the high flow devices, at some part of their instrument arrangement, if you see, they will have a corrugated tube. This is a large bore tube, ventilator tube. So they have to have that to support that high flows. That's the reason. And they need some special machines to deliver this high level of oxygen. So that machines are commercial, and the commercial names include Optiflow, Vapotherm, and in India, very commonly in my hospital, we use a device called Arvo device. This is what we use in India right now, in my hospital right now. So, but you have a lot of other devices also. Optiflow, Vapotherm, all these are high flow nasal cannula devices. This is an emerging thing, please note it carefully. But the trade and the brand names are not important, but you have to know that this needs a special machine. Why you need a special machine? Why you can't straight away? I told you flush rates of oxygen. In the RSI chapter, I told you flush rates of oxygen can be delivered through your routine central line itself. Flush rates can deliver up to 104 liters. So why you need these machines in the first place if you can deliver 104 liters of oxygen to the patient directly? That is not a correct way. Remember, that oxygen that is coming is very cold. When it's flowing at a high velocity, definitely it will be very cold. So it will create a lot of pressure difference. It will induce a negative pressure if it's going at high flows. And number 3, so what's going to happen is like it's going to create a lot of dryness in the respiratory tract. Not only like that low flow 6 liters, 4 liters of nasal cannula can produce dry nose, means imagine like 60 liters, 70 liters of oxygen producing dryness. You will result in sometimes instantaneous dryness, and within 1 hour the patient will start bleeding. It will be very uncomfortable for the patient. That's why you have these devices to produce that high flow in an appropriate way. How they do that? So this device, the specialized device will be there. That specialized device will warm the air mixture, gaseous mixture to 37 degrees C to a nice level so that it's equal to body temperature so that the patient feels comfortable. So warmer will be there. Second, you have humidifier. It humidifies, it warms, it humidifies. And again, humidification is not just like a simple, oxygen bubbling device that you have, bubble humidifier. It is something more than that. They induce water vapor production. For example, you can see the name Vapotherm. What do you mean by Vapotherm? They are going to produce water vapor that they mix with the oxygen. Even though FiO2 will slightly drop, maybe like 0.5% or 1%, but still it can deliver up to 100%. But very light amount of water vapor they mix with that. That's very good actually. They put the water vapor molecules. Why that point is important? There are a lot of advantages. It humidifies oxygen. At the same time, it reduces the transmission of organisms that are transmitted through these water droplets. For example, Pseudomonas. Pseudomonas through bubble humidifier is very, very common. They love water. So when you form a bubble, this bacteria can stick into these bubbles and virus can stick into these bubbles and they can reach the patient's airway tract and they can produce pneumonia, especially in vulnerable patients. Clear? At the same time, if you are producing only water vapor will contain only water molecules. Molecules are much, much, much smaller than your bacterial size and your virus size. So they cannot hold on to these molecules and come and reach. So water vapor has a lot of advantage. So it humidifies, it prevents the transmission of your organisms and creating some new kind of infection. So that and all is not possible. So this humidification has a lot of advantage. They produce water vapor. That's why you have this entire device. Number 3, blender will be there. Blending. So why this blending is important? Blending is really important to deliver a set amount of FiO2 at a set flow. For example, I need 50 liters of oxygen flow at a FiO2 of 60%. These devices can do that. How? They take the atmospheric air and they take the oxygen also that is coming through the tubings and they put some water vapor also for humidification and they blend all these gases together in such a way. There's an algorithm for all these things. They have to blend in such a way and they will deliver the 50 liters of oxygen at a FiO2 of 50%. That's what this blender does. They mix in appropriate proportions. It's like doing a sambar or a rasam, isn't it? So you mix everything in appropriate proportions and deliver to the particular customer. Clear? So this is what this blender does. So you can deliver, for example, you need a 60 liters at 100% oxygen FiO2. Yes, this can do that. 40 liters at 80% can do that. 60 liters at 60%, yes, this can do that. So it can deliver whatever flow you want to set and at whatever FiO2 you want to give, these devices can do that. That's why you need these special devices to deliver this high flow nasal oxygen. Fine. All is well. So now, what are the advantages? What are the mechanisms by which these are effective? They are providing oxygen, all right. So there should be something that is helpful and it is the one that is useful in a lot of conditions. So what is the mechanisms? What is the positive USPs, unique selling points of these devices? Number 1, high flow. High flow itself is a very important selling point. It's a USP here. Why? I already told you the mechanism. Irrespective of the amount of minute ventilation the patient takes, these devices will always produce excess oxygen flow to the patient, which means the patient's ventilation will always be coming from the device. That is, it will be having a set amount of FiO2 only, which means it's a fixed performance. They will take a fixed FiO2 irrespective of the minute ventilation. So that's the first advantage. Number 1, high flow. What is the amount of flow that this HFNC produces? Generally approximately 8 to 70 liters. 8 liters is generally preferred in infant population and 70 liters is produced in adults. Usually this you prefer in adults. Adults generally we keep a flow of 40 to 70 liters depending on the dyspneic status of the patient. Patient is heavily dyspneic, I'll keep it 60-70 liters also. So one first advantage is always the high flow that is generated by these devices. Second, big advantage is that they create a CPAP-like effect. So you have to be cautious. I am telling only CPAP-like effect. I am not telling a CPAP effect. That's continuous positive airway pressure. How can they do that? So for that, let us see a graph. Let us see a graph where I can plot a nasopharyngeal pressure. This is what is claimed by the companies and it seems to work. Yes, I have seen patients improving a lot with this high flow nasal cannula. So I can write time here where I can put inspiration and expiration in staggered lines. Now, Let us assume initially the device is throwing a flow of 20 liters per minute. It's still a high flow. Anything more than 15 liters I consider as a high flow. It's throwing at a rate of flow is happening at a rate of 20 liters per minute. You can see the average nasopharyngeal pressure at this point. This is inspiration and this is expiration. And simply understand. So now, let me assume this device is throwing O2 flow at a rate of 40 liters per minute now. Now I can tell the average nasopharyngeal pressure is somewhere here. It's a little bit high. Now let us assume this device is throwing oxygen at a rate of 60 liters per minute. Now I can see my average nasopharyngeal pressure is little more higher. So you can see when you keep increasing the flows, the nasopharyngeal pressure keeps on increasing, isn't it? So at 60 liters per minute, you can see the nasopharyngeal pressure is very high. This is a continuous positive pressure that is generated. An average continuous pressure is generated in the respiratory system. So that's why I told you it generates a CPAP-like effect. Why I'm telling you again it's like, why it's not a true CPAP, because we don't know about what's happening in the lower airway. It's only a nasopharyngeal pressure that we are monitoring. So because these are delivered through the nasal prongs, but we don't know about what's happening in the lower airways. Remember, to tell it's a CPAP, continuous positive airway pressure, upper airway, lower airway, everything should have the common high pressure. That's a positive pressure throughout the respiration. So this is what we call the continuous positive airway pressure. But here is only the nasopharyngeal pressure that has been tested, not the lower airway pressure. So I cannot call it true CPAP, but it's really generating a CPAP-like effect. So since this nasopharyngeal area is present in the respiratory tract, this must be equal to the respiratory pressure. So you can indirectly equate this to the respiratory pressure, and you can tell this increase the nasopharyngeal pressure, net nasopharyngeal pressure, so that they can increase the respiratory pressure also, they can produce a CPAP-like effect. That's what is claimed by the companies, and that's been demonstrated in patients with cardiac failure, where it is definitely useful, and it has been proven to open up alveoli also. So that's why these devices are very helpful. Number 3, third one, it can replace dead space air with oxygen-rich air. You might be wondering, he is complicating things after things. What do you mean by replacing dead space air with oxygen-rich air? This is again a very good mechanism, how it works. So this will help you in understanding about the pulsed oxygen delivery devices when I'm going to discuss about the long-term oxygen therapy also. But let us understand this concept. So what do you mean by this dead space concept, and how can you replace this with oxygen-rich air? So let me put 2 alveoli. This one alveoli at end expiration, and the next alveoli at end inspiration. So obviously it will be a little bigger. Okay. End inspiration, right? So what will happen during end expiration? So during inspiration, you are going to take oxygen-rich gas and carbon dioxide poor gas, and during expiration and exhalation, you are exhaling carbon dioxide-rich gas and oxygen poor gas. No need of introduction for this. So let us assume this blue is carbon dioxide, and you are exhaling a carbon dioxide-rich gas to the atmosphere at end expiration. At end expiration, it stopped. I should not draw the arrows, but it stopped. So what you are ideally seeing here is, this is the dead space. This is anatomical dead space. And you can see that the dead space is filled with the carbon dioxide-rich gas. And the alveoli is also having a carbon dioxide-rich gas only, because it's exhalation. That's all. Gas exchange would have happened, and that's what you are exhaling. But now let us assume what will happen at the beginning of inspiration. At the beginning of inspiration, what you're going to do, the first air that you're going to breathe in is not the atmospheric air. It's actually the dead space air only. That is already present in your respiratory tract. That is what is going to go in again. Then only your atmospheric air will come in. So which means the initial part of the inspiration will be contributed by this dead space air that is present during exhalation. Exhaled dead space air that you are inhaling once again. What is the volume of the anatomical dead space? It's approximately 150 ml. You know that. So 150 ml, what you are inhaling, initially it's the dead space oxygen only. Sorry, dead space air which contains more carbon dioxide only. Now let us take the air column that you're going to inhale. Let us divide the air column. So this is the air column that you're going to inhale for that matters. So usually let us assume this is the tidal volume that you're going to inhale. That's 500 ml. In this 500 ml, definitely it is oxygen rich, either coming through the ventilator circuit or through the ambient air, atmospheric air. Still it's oxygen rich. It's going to contain a lot of oxygen, right? But please note the fact, this all 500 ml will not be utilized. Already you have inhaled 150 ml of dead space air. So in the 500 ml, you need only 350 ml. So this 350 ml is the true inspired gas that is reaching the alveoli for gas exchange. The remaining 150 is again entering the dead space only. Remaining 150 ml will be present in the dead space, where this oxygen rich gas will not be contributing to the gas exchange at all. Which means during inhalation, the earliest part of the gas, atmospheric gas I'm talking about, not about the gas that is present in the dead space. The gas that is present in the atmosphere, the earliest gas that you take in, the first inspiration that you take, that is what is going to reach your alveoli. The last part, during the end expiration, whatever you are breathing in is going to remain in the dead space only, and that's going to come out without any gas exchange. So which means I can really tell this initial portion of the gas that you are inhaling, atmospheric or ventilator gas that you are inhaling, that is the one that is truly contributing to the gas exchange. This initial 350 ml. The final 150 ml that you are taking is absolutely no use, because it's going to be present in the dead space, which means they are just going to be exhaled in the next cycle, exhalation cycle. That is also one reason why during the earliest part of exhalation, you will not have any carbon dioxide at all. It's just the oxygen rich gas that you are exhaling. So this is the basic idea of this pulse dose oxygen delivery also in LTOT. I'll draw the same diagram once again. But here, what these devices are trying to do is, what if I replace this dead space carbon dioxide gas with oxygen rich gas? What will happen? So first of all, how can you do that? That's the question. How can you do that? How can you replace the dead space gas with the oxygen rich gas? That's where your high flow mechanism comes into play. So first understand, I'm introducing a smoke here. So for you can put a special glass and you can see I'm putting a carbon dioxide smoke here, and there is a puff of smoke. I mean, just imagine there's a puff of smoke here. So I'm trying to blow this smoke. It's not going. It's still present here because I'm blowing with a low flow. Now I'm taking a fan. This is a high flow. It's going to generate higher flows of air. I'm taking a fan and I'm just blowing out. So now this fan will definitely push all the smoke out into other places. So now this smoke will be replaced by the air that is coming from this fan. Clear? So that's what I'm trying to do here. So because it generates such a high flows, this cannula that is placed here, generating high velocities of oxygen, because the cannula size is very small. You know, there will be something called a Bernoulli effect. That also you have to know. So there is something called a Bernoulli effect. So where whenever a fluid column or a gas column is moving on, when it enters a constricted segment, its velocity will increase multifold. But remember, the pressure will drop, but the velocity will increase. But it always, a medico understands in a reverse way that the pressure is increasing. Always he gives an example of a hose pipe, where when you press the hose pipe, the pressure increases. It's not the pressure that is increasing, pressure will actually drop. The velocity is the one that is increasing. That's what you are misconceiving as a high pressure. If you really want to understand how Bernoulli works, go and stand on the middle of the hose pipe, not at the end. When you stand in the middle of the hose pipe and you see at the end, definitely the pressure will drop. In that area, the velocity only will increase. Pressure will not increase, it will always drop only. Understand? Okay. So this is what happening in a Bernoulli. So your velocity is increasing. So what will happen is, since such a high flow of 60 liters, 70 liters of oxygen flow is happening through a small nasal cannula that is present in the nose, that's generating a high velocity of air that is coming out through this constricted small nasal cannula, and that high velocity will go into the respiratory tract, like in an energized manner, because they have high kinetic energy because of high velocity, and they go in a very energized way, and they will just, because of the high flows, they just flush out the dead space carbon dioxide rich air. So this is the air I'm talking about. The dead space air that is CO2 rich and oxygen poor. They'll flush out that and they will go and occupy that area. Because there is a small gap during inspiration and expiration and expiration and inspiration. So I'm expiring, exhale, and I'm not taking breath immediately. There is a gap. So that gap is utilized by this machine very well, and they're going to flush out all the dead space carbon dioxide rich air and they will replace that with the oxygen rich air. This is claimed by that particular company also. So, and this been proved with some theoretical experiments as well. Fine. So this replacement with the replacement of the carbon dioxide and rich and oxygen poor dead space air with oxygen rich air, oxygen rich gas is advantageous. Why? Because the initial portion you are inhaling the dead space air only, which is useless. It's actually the exhaled gas you are re-inhaling again in the normal physiology itself. But if you are inhaling an oxygen rich gas in the initial phase itself that is coming from the dead space, automatically your total oxygen requirement through the breathing will reduce, which means what I'm indirectly telling is your minute ventilation will definitely reduce. There is no doubt about that, because you are giving extra oxygen through the dead space also. So this will definitely reduce the work of breathing. This will definitely reduce the work of breathing also. Very, very, very important point. So that is the reason why whenever you give a high flow nasal cannula, the patients who are very, very sick may look very nice. They'll be extremely comfortable with the high flow nasal cannula. And that might be a false notion also, because appearances are deceptive. The patient might be suffering from some serious disease, lung or cardiac disease, but with this HFNC, the patient look apparently much better, well perfused, good saturation, they'll be comfortable. Discharge the patient, you're dead. Not you, the patient will be dead. And indirectly, you are dead as well. So don't do that. So that's one problem with this HFNC. They can make the patient apparently look much, much better because of this kind of mechanisms of action. So that's why you have to be extra careful. So whenever they are in HFNC means you have to assume that they are sick. That's it. So they are looking apparently well because of the high flow nasal cannula. And what are the uses? Where are the uses for this? And what are the conditions that get benefit from this high flow nasal cannula? Simple. Condition number 1 is cardiac failure. Heart failure, definite symptomatic improvement because it does produce a CPAP-like effect, which is definitely beneficial in cardiac failure. At the same time, gas exchange is poor in heart failure. So this is going to get a good gas exchange. So that's why heart failure. Second, post-ROSC. That is after cardiac arrest, return of spontaneous circulation proved to be extremely beneficial. Number 3, post-cardiac surgery. Very, very good. After cardiac surgery, respiratory failure is very, very common. So in those conditions, you can definitely use this HFNC. Type 1 respiratory failure, hypoxemic respiratory failure. Very, very helpful. Proven again. Multiple trials. Number 5, post-extubation. After you have extubated a patient who was on endotracheal tube. Very helpful, because after extubation, there's a lot of chance that sometimes you might re-intubate the patient. This reduces the need for re-intubation. Excellent, isn't it? Number 6, in patients who are DNI, you would have encountered these terms DNI, DNR in your ICU. DNR means do not resuscitate. DNI means do not intubate, where the patient himself or the very close akin, like patient's husband or wife might be telling that because of the terminal condition of the patient, no need to resuscitate or no need to intubate the patient. So the patient might themselves give it in writing, don't intubate me. You can't intubate in that case. So this acts as an alternative in terminal illness, where the patient don't want to intubate, but still this keeps them comfortable without getting intubated. Alternative to intubation itself. It can act as an alternative to NIV itself. That's being told nowadays. That's a trial going on right now, whether it can be a suitable alternative to CPAP and BPAP. Such a good device this is. That's why, I am really a big fan of this HFNC. It makes the patient looks Planck point better. That's it. So immediately the patient will get better. How much ever sick they are, at least they may get relatively better. And the COPD, very, very cautious, because this should not be, such a high flow of oxygen cannot be used in hypercarbic states. In COPD patients who are not hypercarbic, you can use this HFNC, but in excessive CO2, PaCO2 is very high, means it's really, really, really dangerous. Such a high flow can worsen the CO2 retention. I told you in COPD chapter itself, where there's a lot of problems are there. Clear? Because of Haldane effect and VQ mismatching, you might result in some progressive CO2 retention, and more problems. So these are the some of the uses of this high flow nasal cannula, but lot of future uses are there, which I might update in the future videos if they are getting updated. So I am really hoping for the wonderful effects of this HFNC, but I hope that clearly every tertiary hospital has this beautiful device. Anyway, so we are moving on from HFNC. I took a little long time on HFNC because I love it. That's why, and it's a very, very important emerging device. This will move on to the face masks. Face masks, clear? So face mask devices, first obviously is a simple face mask. Simple face mask. Very simple device. It's just a mask like a nasal cannula only. Instead of the tubing will be the same. Just instead of the prongs, you'll have the mask. That's all. This is a simple face mask. And what's the FiO2 it can deliver? Again, unreliable because this is a low flow device only. Typical low flow device. FiO2 it can deliver is approximately somewhere around 35 to 50% at oxygen flows of 5 to 10 liters per minute. But please choose always more than, so it should be 6 actually in adults. So please choose oxygen flows always more than or equal to 6 liters, because less than 5 liters, there is definite carbon dioxide rebreathing. Simple reason, because when you put a simple face mask and close the face like this, what's going to happen is they are going to take in oxygen, because this face mask will act as a reservoir. Reservoir for what? During inhalation, they'll act as a reservoir for oxygen, right? So the oxygen comes and stays here, so you take up the oxygen. But during exhalation, they might act as a reservoir for carbon dioxide also. If this oxygen flow is not sufficient, if you go very low oxygen flow means, what will happen is progressively the oxygen incoming is very less, but carbon dioxide outcoming from the respiratory tract is very high, which means there will be more of a carbon dioxide reservoir than oxygen reservoir. So you have to give it a sufficiently high flow so that this incoming oxygen will flush out the carbon dioxide out. So that's why it should set at least 6 to 10 liters per minute, so that your oxygen will start flushing the exhaled carbon dioxide out of the mask, so that you will result this mask being a good reservoir for oxygen. If you set it less than 5 liters, this might result in a CO2 rebreathing also. That's the idea. So O2 flow should be at least at 6 to 10 liters per minute, and there will be, again, FiO2 is completely unreliable because it's a low flow device. A lot of reasons why it is unreliable. Because of the room air entrainment, because atmospheric air will dilute. You're not going to put a tight mask anyways. The mask will be little loose only to the patient, and definitely when the patient is inhaling, the atmospheric air also, because negative pressure created, so atmospheric air will definitely come through the sides of the mask. At the same time, some CO2 rebreathing might happen because of the exhaled gas, something will be sticking on here and there. A lot of other reasons are there, so this is not a very reliable device to produce a correct amount of FiO2. So it's unreliable device to an extent. In the earlier stages of respiratory failure, it might be helping, but it's not definitely reliable to an extent. Okay. And what are the disadvantages? What are the disadvantages? So disadvantages, number one is unreliable FiO2 because of the atmospheric air entrainment. Unreliable FiO2 because your atmospheric air can move through the sides, CO2 can be retened in the mask, which can act as CO2 reservoir instead of O2 reservoir if you're using a low flow. So a lot of factors are going to affect the CO2, the FiO2. Again, it's unreliable FiO2, and again it depends on the minute ventilation, because if the patient breathes very fast, the oxygen flow may not be enough. We are giving only at 6 to 10 liters, which means they have to take in from the other areas only, from the atmosphere only. Clear. And at the same time, it also depends on your atmospheric air entrainment and the mask fit especially. If the mask fit is very loose, there will be literally no oxygen delivered to the patient from the device. So at least it should have a decent fit. Then only you will get a better FiO2. And second problem, some patients may feel claustrophobic. So because it closes the patient's face like this, so somebody can feel this as a claustrophobic device. So they may not accept. You would have seen, especially agitated patients, when you keep face masks, they will become more agitated. They don't want it, that makes them feel claustrophobic. Especially don't use this in delirium patients and all. This is really not a good device. I'm telling you, this is not a good device at all. Nobody likes this. Claustrophobia. And I've seen many times they put a face mask and the patient doesn't like it. They will tie the patient and they'll put the face mask. No, don't do that. That's all is, I mean, not a humanitarian thing. They don't like it. That's all. Somebody, like being claustrophobic means they will get irritated. Just remove them and give an alternative device like nasal prongs, and or probably HFNC or some other device like an NRBM. So don't do this, like forcibly putting the nasal face mask and all. And the third one is aspiration of vomitus. This emesis aspiration is again very common because this is a closed mask, and again some openings are there, but still if you vomit into the mask, and again there is a lot of chance that you might re-aspirate. So there is no sufficient big openings at all. So that's one problem is there. So these are the three problems, these are the three disadvantages of this simple face mask. And to combat these disadvantages, they have devised this kind of specialized mask. This is called an oxy mask. This with a diffuser system. Face mask with diffuser system. These are specialized masks. So where you can use this, I'll tell you. At the same time, if the patient, the main problem is claustrophobia, there is one other alternative also. If the main problem is claustrophobia for the patient, then you can have one more alternative here. This is a face tent. Face tent. It will not hold the patient's nose to mouth like this. It will come like this only. From the jaw, from the mandible, it will be coming like this. So it will be behind the patient's eye view, vision line. So the patient won't feel claustrophobic. Only if it comes near the patient's eye line, they will feel claustrophobic. It's here like this, so the patient will not feel claustrophobic. Instead, it's like something is there, that's all. So this might be an alternative. This is called a face tent. It's like a high flow device only, but it's not going to provide a good FiO2. I mean, the reliable FiO2. So I will not be putting under a high flow device in the first place. Clear? So this is the face tent. But on the other hand, we didn't complete the discussion on the diffuser system. So these are masks with diffuser system. This is a patented diffuser system that only one company has this. That company name is Oxymask. Oxymask. This is a patented diffuser system. Okay. So you can see, despite having big holes, you can see how much big holes they have. This mask has. Still they produce an FiO2. Still they can deliver an FiO2 of approximately 25 to 80% because of the special diffuser system they have. So what is this diffuser system? They have a pin. You can see in this example, they have a pin over here. This is a special diffuser pin they have, which actually, form certain vortices of gas. For example, they form vortex of oxygen here, which will be directed towards the nose and the mouth. So that's how that pin is located, and that's a special patented system that creates vortices, rolls of gases that will actually directly directed towards the nose and the mouth, which means instead of the gas that is present throughout the mask, this pushes the oxygen directly into the mouth and the nose specifically. So that's the reason why it is able to produce like 25 to 80% of FiO2. It's a very simple principle, that's all. But still, it's a patented thing. They devised it, Oxymask company. And you can also see the fact that rebreathing of carbon dioxide is never a possibility because it's not a closed system. You have a big hole like this. So whatever exhaled carbon dioxide is there, that completely comes out through the hole. So there is no probability of rebreathing carbon dioxide. That is the main reason why this mask is successful. And it will increase the FiO2 to a great extent, like up to 80%. The company claims it to 90-95, but usually, practically speaking, it comes only up to 80%. And it has been proven in multiple trials also. They have compared this Oxymask with a simple face mask side by side and a head-on-head trial, where clearly Oxymask produced heavier saturation, high saturation compared to that of the face mask. Face mask failed in that, simple face mask failed. So Oxymask is good. Probably if you have it, it's very inexpensive only, but in India, very limited centers have this Oxymask. So it's a very good thing. If you want to use a face mask, I would like to go towards an Oxymask instead of a simple face mask. And again, because of the big openings, there is other disadvantage of that simple face mask that is also addressed here. That is the aspiration of vomiters. So because of big openings are there with this mask, that vomiters can easily come out, so that aspiration risk of vomiters is very less. So these are some of the important face mask devices that you have to know first. But there are two other face masks, like it's not completed. So two other masks are there. One is the partial rebreather. Partial rebreather. I mean, it's not a big thing at all, man. All these things are very, very simple. A simple staff nurse will convert this simple face mask into a partial rebreather. Simple. You have a face mask and you have a oxygen tubing connected to it. Just pull the oxygen tubing and connect the area that now you have removed the oxygen tubing and there will be a hole, isn't it? Through that you connect a reservoir. That's it. And in the reservoir you connect the oxygen. That's all. This becomes a partial rebreather. Simple. Just you are going to connect an extra reservoir to the face mask by pulling the oxygen tube out, and the oxygen tube will go to the reservoir now. So you can see this example how the staff nurse here have did this. First they are pulling out. So you can see this, this oxygen connecting area in the simple face mask. You just pull it out. That's what she is doing here. She just pulls it out, and after pulling it out, this is the reservoir here. I'll go back to the next image. This is the reservoir bag here. This is the reservoir bag. So this area will connect to the oxygen port very nicely. So now you fit it to the simple face mask, and now your Maggi noodles is ready. That is, your partial rebreather is ready in a couple of seconds. Very easy to create. But this does produce a little bit of higher FiO2 compared to the simple face mask. Like FiO2 delivered by this will be 50 to 60%, where simple face mask will deliver only like 35 to 50%. We saw that. So it will deliver 50 to 60%. And oxygen flow rates can be set at a bit higher at 10 to 12 liters per minute, because you have the reservoir bag, comfort is there. So they can hold a little bit of more oxygen. But some rebreathing of carbon dioxide will happen. But still, it is not a big problem, because this is not having any valves. So when you are inhaling, the gas comes from the reservoir. When you are exhaling, that gas obviously like it goes through the sides of the mask, but at the same time it can also go, because you have a reservoir there, it can also go into the reservoir. But remember, I told you, when you set a high flow, because the amount of carbon dioxide that you blow out through exhalation might be at a much lesser flow rate compared to the oxygen that is coming in, which means oxygen that is coming in having more flow into the reservoir means carbon dioxide movement into the reservoir will be very, very less, because you feel resistance, because the flow itself will create a resistance, oxygen flow into the reservoir. So you can minimize, that's why you are setting at a high flow here. You can minimize the rebreathing of carbon dioxide by setting high flow of oxygen into the reservoir, so that the carbon dioxide doesn't enter into the reservoir and goes only into the atmosphere and the patient exhales through the mask. But this doesn't have any valves. Understand, this doesn't have any valves. If you set a low flow in the reservoir, when you are inhaling, and after that when you exhale, carbon dioxide rich gas will move into the atmosphere. At the same time, it will start moving into the reservoir bag also, which you will be rebreathing again. So that's why set a high flow of oxygen that is coming into the reservoir bag, so that you will not rebreathe carbon dioxide. At least you can prevent it greatly. So clear? So it's a good device to an extent. You can use that in emergency scenarios if you need a little higher FiO2 to be delivered. Clear? And again, it has some problems like simple face mask issues only. Same problem will happen like your FiO2 is still unreliable. It delivers a little high FiO2, but still it is not reliable. At the same time, aspiration of emesis is a problem, claustrophobia is a problem. All these things are a problem for this partial rebreather mask also. Now you know how to convert a simple face mask to a partial rebreather mask. Okay. Now this is a non-rebreather mask. This is a very, very important mask in your entire emergency room, because whenever you go to emergency room, every staff nurse will be talking this NRBM, NRBM, NRBM. So what is NRBM? It's a non-rebreather mask. So remember, there is a risk of partial rebreathing in that partial rebreather mask, because you know it's a simple face mask with the reservoir. So carbon dioxide is going to enter. You can prevent by high flows of oxygen, but still some CO2 will enter. That's why we call it as a partial rebreather mask. But this NRBM will not have any carbon dioxide rebreathing at all. That's why it's called a non-rebreather mask. Simple. How will you create a non-rebreather mask? You have to change the mask and put a valve. Where you have to put the valve? You have to put the valve in the reservoir area. That's all. So now what I'm going to do is, you can see you have It's like a face mask only, and you can have the reservoir connecting area. This area will have one-way valve. This one-way valve will be allowing gas movement only into the face mask. Clear? From the reservoir back. It will not allow the reverse movement. This movement cannot happen. That's why the one-way valve is located there. So rebreathing is literally impossible, number one. And second thing, this mask is having a more better fit compared to the traditional face mask. Better fit, so it have a good tight seal. Number three, it can produce high levels of FiO2. For example, theoretically speaking, it can deliver a FiO2 of, NRBM can deliver FiO2 of 80 to 95%. The reason is tight fill. At what O2 flows? O2 flows should be at least 10 to 15 liters per minute. I mean, this amount of O2 is important for actually maintaining the reservoir. Otherwise, the reservoir will collapse if you breathe very fast. So to maintain this reservoir, you need this high O2 flows, definitely. So now, since it has a better fit, again the entrainment from the atmospheric air will be very less because it fits very tightly. So the oxygen is not, the atmospheric air is not sucked in through the sideways. Okay. At the same time, you have another two valves also. You have two valves here also. You can keep the two valves here. There is no valve right now, but I'm just showing here. You can keep two more valves also. These are exhalation ports. That's called exhalation port, which means when you exhale, these valves will open and the gas will move out into the atmosphere. And during inspiration, these valves will get sucked in and they will close. So which means again you are preventing the atmospheric air from moving inside during inhalation. So which means during inspiration, gas flow in another way will not happen. This is a function of the one-way valves. So you are keeping two one-way valves, one at the level of reservoir and two valves. These two have the same function. These are exhalation ports and two at the level of the face mask. Clear? So this is an inhalational valve where it will open only, the reservoir valve will open only during inhalation. So during exhalation, it will go down until close. In the face mask, you have two valves. These are exhalation ports, and this will open only during exhalation, and during inspiration, it gets sucked in back, and they will close off. Clear? So by this principle, you are preventing, and again coupled with the tight fit of the mask, you are preventing the atmospheric air from moving into the mask. So you prevent the dilution of the oxygen that is coming from the reservoir. At the same time, the carbon dioxide moves out only into the atmosphere. At the same time, your carbon dioxide entry, exhaled gas entry into the reservoir is also prevented by the valve that is present there. It's all about the valves. So this is a NRBM. This is a function of NRBM. That is how it can produce a good amount of FiO2 of 80 to 95%, even though theoretically it can reach 100%, but practically only 80 to 95% will reach. It's not like a infinitely tight fit, isn't it? There will be some leakage around the mask will still be there. You cannot reach 100%. 95% you can reach up to, theoretically. Clear? So this image will clearly show whatever I told you. This is a one-way inspiratory valve which will allow gas flow only in that particular direction during inspiration. And these are the one-way exhalation valves where the gas flow only will happen from inside to outside. It will prevent the atmospheric air entrainment. So this is how it can produce a FiO2 of 80 to 95%. Clear? So and again, this is the tubing that is connecting the oxygen flow. This is the oxygen flow which you should set at least 10 to 15 liters per minute. This is the oxygen flow that you should set into the NRBM. Very, very commonly this you can see in the emergency. And remember, this needs a very tight fit. A correct fit mask is very, very important to deliver this much amount of FiO2. Otherwise, again, atmospheric air will come and dilute your your entire oxygen concentration. So don't do that. So it should have a tight fit. So this is one mask that you will very, very commonly see in the emergency room. So you have to know about this. And this is a typical NRBM. You can see these are the valves. I want to show the valves. That's why I kept this image. You can see this is the inspiratory valve. You can see a white color round there. That is the inspiratory valve here. And this is the expiratory valve. Remember, for safety reasons, they do not close both the valves. And that's also one reason why FiO2 cannot be reached 100%. Because I told you there are two expiratory valves, isn't it? For safety reasons, most of the time, no staff nurse will close both the valves and this inspiratory valve also. Suppose if the mask is very tight fit and both the valves you have closed, these are expiratory valves, they close in inspiration. and due to some reason your oxygen flow from the central line is stopped, whether there is some problem in the circuit that is delivering oxygen to your emergency, or if the oxygen cylinder changing fellow in the room is forgotten and slept and he forgot to change the cylinder. So suddenly if the oxygen flow stops, if you have closed both the exhalation ports and the inspiratory valve also, the reservoir will not fill at all and the patient might get extremely dyspneic. So that's why always they leave the one port open, practically speaking. They will never close both the ports. They leave one port open so that in case of dire emergencies, if the oxygen flow is not happening and the reservoir is not getting filled due to some technical error, still the patient might breathe in the atmospheric air through this open port. That's a very important thing. So that's why no staff nurse will close both the ports. That's what this clearly showing. In this area you won't keep the valve. Usually only one side they will put the valve, expiratory valve. Clear? Now let us move on to the enclosure systems. There are two types of enclosure systems. Both will be used in children and infants only. Only children and infants you can use. Typically in infants, not more than that. This is for them only. Two types are there. One is the oxygen tent and second is the oxygen hood. Tents we don't use nowadays because again the oxygen delivery is unreliable. The O2 flow must be 10 to 15 liters per minute and the FiO2 delivered will be approximately 50%, but even lesser. But one of the main problems with this tent is they form a mist around the plastic sheath so that it obscures the view of what the child is doing inside, or whether the child is gone for coma or suffering from respiratory distress, we have no idea. The mist will obscure the view. That's a big problem with this oxygen tents. On the other hand, oxygen hood is a very, very common device used for infants, especially in NICUs you can see very, very commonly. The infants will tolerate very, very, very nicely this oxygen hoods. It's a little bit more reliable and it can deliver an FiO2 of approximately 80 to 90% with oxygen flows at 10 to 15 liters per minute. So you might ask me, sir, whether it's a low flow or high flow device. These are high flow devices only, no doubt about that. Because how can I ask high flow? Because this 10 to 15 liters per minute for an infant is actually high flow. The minute ventilation never exceed 10 to 15 liters per minute in an infant. So don't worry about that. So definitely it's a high flow device only. Even oxygen tent also. But depending on what the population you are addressing, here the infant, so definitely it's a high flow device for them. 80 to 90% good, well tolerated by the infants, very, very good. In NICUs, very common, and you can see a hood-like device on the patient's head, isn't it? So it will cover. Why you cannot use beyond infancy? Because the child's head will be too large to fit into that hood. And sometimes the child, as it grows, they might push that hood out and they may not like it. So that's why. So it's good for infants, as simple as that. Then let us move on to the ventilation bags. There are two types of ventilation bags. One is the self-inflation bags and second one is the flow inflation bags. These flow inflation bags are also referred to as anesthesia bags. Self-inflation bags, everyone knows that. AMBU, they call it AMBU. But remember, AMBU is not the name for this bag, even though I don't know. Many textbooks even give that expansion for AMBU, that's called an artificial manual breathing unit. But no, that is not correct. AMBU is a company that produced the self-inflation bags first in 1953, to be exact, precise, I think. So that's AMBU, that's a company. So similarly, we have a lot of other companies like Laerdal. In fact, in India, most of the self-inflation bags are Laerdal bags only. But still, we used to call them as AMBU because, I mean, it's not a sin, obviously. We can call that as AMBU. But many of them are the silicone Laerdal bags and a lot of different types of companies do that. And you have a company called Mayo that also does. You have a company called Signer. A lot of companies are there. But AMBU is the original inventor. So it's a company. So AMBU changed the way this, this is also called as, otherwise AK, also called as manual resuscitator. Manual resuscitator and manual breathing unit, MBU. Manual breathing unit, that's also named. That's why they mistook as artificial manual breathing unit. No, it's not the case. It's manual breathing unit is a separate name. So it changed the face of how resuscitation has been done. Before 1953, it was only the mouth-to-mouth resuscitation was there, but it actually changed the face. So this AMBU can used in emergencies to artificially ventilate the patient by just putting a tight mask and compressing it. You need not do a mouth-to-mouth resuscitation. So that's why it completely changed the way how we did the resuscitation. That's why credit goes to AMBU for inventing this bag. That's why we still give the name ambu bag. Flow inflation bags, on the other hand, is something different. Remember, self-inflation bags, when you compress them, even when you don't do anything, you just take the hands off, it will automatically inflate. It is made of special material, usually silicone. That's what they are made of. But this flow inflation bags, also called as anesthesia bags, you can see in the OTs very commonly, where the anesthetist will be pressing that flow inflation bags. Sometimes you can see in the Bain circuit also, they'll be pressing that, isn't it? So these bags, when you press, the re-expansion depends on the gas flow. In ambu, whether the gas flows or not, doesn't matter. It will reinflate automatically if it's connected to the atmosphere. But this flow inflation bags will expand. After you compress, it will re-expand only if there is oxygen flow happening sufficiently. Otherwise, it will not inflate. At the same time, it should not have any leak outside. The flow comes inside, means also it will not inflate automatically. You should have a tight seal around the face. If the oxygen doesn't leak only, then only it will start expanding. If you don't have a tight seal, again it will start leaking and the bag will not expand properly. Okay, so there are a lot of things. So it's a little bit challenging. That's why newcomers feel a lot of difficulty in using this flow inflation bags compared to that of self-inflation bags. Self-inflation bags is for everyone. So paramedics can use, staff nurses can use, a duty doctor can use, a newcomer can use, anyone can use a self-inflation bags. That flow inflation bags is a bit challenging. Let us discuss about the differences in some time. But before that, let us first finish off the self-inflation bags principle, how they work. Let us put a line diagram on how this self-inflation bag principle will work. So this is the outlet area and this is the air inlet area, that's the air outlet area, and this is the self-inflation bag made of silicone usually. So now let us concentrate on the valves that are present. Remember, this inlet is guarded by a inlet valve. It's a one-way valve. And again, outlet is guarded by another one-way valve called an outlet valve or a patient valve. That's what we call. So both are one-way valves. And this forms the crux of the ambu or any self-inflation bag. Even though different companies are there, everything works by a similar principle. But the location of these valves may be a bit different in different companies because they have to show some change and difference, isn't it? So that's why they are a little bit different. But the mechanism is the same. This is how it works. So this inlet area, let us concentrate on that. So you have two ports that are connecting here. One is to the oxygen. So this is the oxygen inlet. So there will be something called an oxygen nipple and you have a reservoir port. So this is a reservoir port and this is the oxygen nipple. Through the oxygen nipple, you will be putting a tube. There is an oxygen tube where it will be connected to the oxygen source. So through this, the oxygen will be flowing into the ambu bag, isn't it? So other area, like this is optional. This end, either you can leave it open to the atmosphere or you can connect it to a reservoir bag. This is your option. Either you can connect to the reservoir or you can leave it open to the atmosphere. That's your wish. But let me tell you why you have to connect to the reservoir. But now, first of all, what are the functions of these one-way valves? Remember, whenever the ambu is compressed or whenever the self-inflation bags are compressed, you're going to increase the pressure inside. This increased pressure will move this inlet valve out and it will close the inlet valve. On the other hand, this will move the outlet valve out and it will open the outlet valve or the patient valve, which means during compression of the ambu bag, when you're compressing the ambu, the air movement will be always in one direction, that is out. That's it. So now when you are leaving the ambu, because it's a self-inflating bag, even when you don't do anything, and when you leave the hand, it automatically will be expanding. So now what happens when you are reinflating? When you are reinflating the bag from compression, there will be a pressure drop inside that will definitely suck in this outlet valve and they will close the outlet valve. At the same time, they are going to suck in the inlet valve and they are going to open the inlet valve when you are reinflating the bag, when the bag self-inflates. So this time, obviously the gas will flow into the ambu, which means when you are compressing, gas flow will be only outside. When you are releasing, gas flow will be into the bag, into the inside. So that's all. So when you don't use any reservoir, so what will happen? Now, when you are releasing the bag, see, only one time the inlet valve will be open. That is when you are releasing the valve, releasing the bag. When you are compressing or when you are just keeping the bag static without doing anything, that time and all, the inlet valve will be closed only. Only moment where the inlet valve will open is when you are releasing the bag, when it is going from the compressed portion, deflated portion to inflated portion. So what's going to happen here? So when it is getting inflated, that time it's going to create a negative pressure so that it sucks in air from the other areas through the inlet valve. So when it is not connected to the reservoir, the oxygen will move inside. At the same time, the atmospheric air also will move inside, which means it's open to the atmosphere now. So oxygen, atmosphere, both will move. So this oxygen that is coming is 100% O2 because it has nothing else. It's oxygen flow, pure oxygen. Atmosphere will contain only 21% oxygen. So both will mix in the self-inflation bag and they will produce only a net FiO2 of 40 to 45%. This is a very, very, very crucial point. Why? Because when you do not use the reservoir bag, the FiO2 you will be achieving is only 40 to 45%. Now let us see what will happen if you use a reservoir. So let us, draw only the inlet area now because we are concentrating on that only. So this is the oxygen nipple that is connected to the oxygen tubing. Isn't it? Oxygen tubing, which is going to put a gas flow of 100% oxygen, whatever flow rate you put. And now let us assume this reservoir area, now it's properly connected to a reservoir bag. So I told you the inlet valve will always be closed. The inlet valve will always be closed in all the points except the time when you are releasing the bag. I mean when the bag gets inflated. Except that point, at all the points, the inlet valve will be closed only. But the oxygen flow is keeping on happening, isn't it? Through the inlet valve. But since the inlet valve is closed during the time when the bag is not used or during the time when the bag is getting compressed, the inlet valve will be closed so that the oxygen that is coming in through the oxygen nipple cannot go into the inlet valve. Instead, it goes into the reservoir bag and now the reservoir bag gets filled with 100% oxygen. Now the reservoir also will contain 100% oxygen only. Now let us assume you are compressing and now you are reinflating the bag. So now you are releasing the bag. So during that time, it will change from closed portion to open portion. So now the moment it opens and creates a negative pressure, because the negative pressure is there, that's why the inlet valve is opening. So now it's going to suck in gas through the inlet valve and the gas that is present in the reservoir is also 100% oxygen. The gas that is coming through the oxygen port is also 100% oxygen. So which means you will result in 100% oxygen in the self-inflation bag. That's the idea of a reservoir. So with the reservoir, you can theoretically and practically achieve 100% oxygen or 100% FiO2. Very, very important point. Clear? Without a reservoir, you will not be able to do that. So that's why it's always better to use a reservoir. And there are a lot of other things that is present in inlet area. There will be some safety mechanisms also. Lot of bags will have safety mechanisms, even though some will not have. If you don't have the safety mechanisms in the inlet area, in the bag, at least there will be safety mechanisms in the reservoir area. That's called the reservoir safety mechanisms, reservoir safety. So why we are having this much safety mechanisms? Suppose if you have connected to the reservoir and due to some reason your gas flow has stopped. What will happen? Then how the bag will inflate now? So because now if you are connected to the reservoir and you have oxygen that is coming through the oxygen inlet, now due to some reason the oxygen flow has stopped because of technical or manual error. Now when you are trying to inflate the bag, when you are compressing and inflating the bag, the inlet valve will open, but there is no gas flowing into the reservoir nor coming from the oxygen nipple also. So this is a deadly scenario. The bag will not inflate at all, then the patient will not get ventilated and you are in a soup. So to avoid this, what will happen is there will be a safety valve which will clearly open in these scenarios. So they will open in case of this extreme negative pressures and they will at least bring in the atmospheric air so that you can start ventilating the patient. Similarly, when you have too much of air inside the ambo or the reservoir, so now another safety valve will be there. So suppose if you have a reservoir valve, when the reservoir bag inflates too much because of excessive flow and the patient doesn't need that much, so this valve, another safety valve will be there that will open, that will leak some of the pressures and the gas into the atmosphere, so that it will prevent the rupture of the reservoir bag. So these are some of the safety mechanisms that you can have at the inlet area. Fine. Now what about the outlet? Outlet, you have some optional things are there. Let us concentrate on the outlet now. Outlet, definitely I told you there will be a patient valve or outlet valve. So this valve can only open up and put the gas only in this direction. It cannot go in the reverse direction at all. It cannot make the gas enter into the self-inflation bag. That's the function of this simple valve. And this end will be connected to the face mask, obviously. This end will be connected to the face mask, yes. Now what if the patient exhales? If the patient exhales, I told you this valve will definitely won't allow the gases to escape into the self-inflation bag, because that's the function. It will not prevent, it will not allow the rebreathing at all. So how this mask will, how the exhaled gases are going to go out then? So a lot of the ambu bags and any other company also will have this expiration ports. These are called as exhalation ports near the outlet valve itself. Exhalation ports, where the outlet valve will close. It will not allow the exhaled gas to go into the self-inflation bag, but this exhalation ports will open so that the exhaled gas will leak into the atmosphere. This is the exhaled gas that's going to leak into the atmosphere. Clear? Simple. That's all. You can put a lot of other optional things also in this. So there are two optional things that you can keep here. One is called a PEEP valve. I can set a PEEP valve here in the exhalation port. Near the exhalation port, I can put a PEEP valve. So PEEP is positive end expiratory pressure. How will it generate a positive end expiratory pressure? Because during expiration, you are generating a positive pressure. I'm talking about normal lung recoil. Normal lung recoil itself will produce a positive pressure. We have studied in physiology itself. So, obviously, why they produce positive pressure? To push the air out of the lungs so that they calibrate to the atmospheric pressure. Suppose what if you capture some of the positive pressure and prevent it from leaking outside? Obviously, it will result in a capture of that positive pressure during expiration, which means the positive pressure is not leaking. That's what is called a positive end expiratory pressure. The PEEP valve does exactly the same. It captures some of the positive pressure that's leaking during the atmosphere and prevents the leaking of this pressure and keeps intact within the circuit. So if you keep a tight mask, they can generate a positive pressure within the respiratory system. That's what we called as a PEEP. So you have a PEEP valve also. You can attach them. So this can deliver a PEEP also if you have a PEEP valve with you. And second optional entity you can do is you can put a viral filter, especially when you are living in this COVID related environment right now. So it is also very important to understand. You can add a viral filter also. So why viral filters? That will be between the mask and the expiratory port. So when you add a viral filter after the mask immediately, so gases that are passing through the viral filter will be filtered of viral particles, and the gas that is releasing into the atmosphere will be free of virus. At least the amount of virus will be less, so that the healthcare personnel will get less chance of infection. So that's the reason why you use viral filter. Please use viral filters in the COVID period when you are using an AMBU. Very important point. So this is how it functions. And one more valve I didn't tell you in the expiration. This valve is definitely seen in many of the devices. This is called a pop-off valve near the outlet area only. So what do you mean by pop-off valve? Otherwise referred to as a pressure relief valve. Suppose newcomers, especially, they can do over-enthusiastic bagging. They can compress the AMBU very badly so that you will generate a very high positive pressure. So when you are generating a very high positive pressure, that may damage the lungs of the patient, isn't it? Barotrauma. So that is the reason to avoid that high pressure development and transmission to the lungs. So this valve will open up whenever you are generating a very high pressure. So for example, you can have a fixed area. For example, pediatric patients will have set value at 40 and adults will have a set value at 60 centimeters of water. When you exceed this pressure, this valve will open and will release the pressure into the atmosphere, dissipated, so that you don't deliver that much high pressure to the patient. Clear? So this is again a safety valve at the outlet, pressure relief valve or the pop-off valve. So this is a general arrangement of any self-inflation bag. Clear? So this is a Signer bag. I mean, it's not an Ambu. This is a different company, Signer, but looks like an Ambu, isn't it? So Ambu is a different company. Okay. So now what all you can see? You can see the inlet area. When you see the inlet area, this is the reservoir. And you can see the oxygen tubing. And this is the oxygen nipple, oxygen inlet and tubing. This is the oxygen nipple where the tubing is connected. And this is the safety valves. Either it can be seen in the reservoir connector or it can be seen in the Ambu itself. So some safety will be there. So clear? Either to suck in the atmospheric air in case of insufficiency of gases in the self-inflating bag, or it will leak some of the gases outside in case of large amount of gases are unnecessarily present. So safety mechanism will be there. One valve will open into the atmosphere, one valve will suck in air from the atmosphere. That's why you have two valves here. And this is the reservoir connection. This is the reservoir port or reservoir connection. And this is the self-inflating bag. You know that. Near the outlet you have this pop-off valve. This is the pop-off valve or the pressure relief valve. And you can see the PEEP valve attached in this. So this is the PEEP valve attached near the expiratory port area. And you have an expiratory valve that will prevent the movement of gases into the self-inflation bag again. It's a one-way valve. And finally you have the mask. Mask should be extremely tight fitting. Very important. So it should not leak the pressure out. So this is very easy to use. Ambu. These are the parts of the Ambu. And this is a line diagram again. You can see the same thing. This is the oxygen inlet and this is the reservoir socket and this is the inlet valve. And similarly you have the outlet valve. This is the patient valve, otherwise referred as outlet valve, and you have exhalation ports where whenever the patient expires, whenever the patient exhales, the gases will flow like this. Whenever you compress the Ambu, the gases will flow like this. So that's the idea. So it will prevent the rebreathing of carbon dioxide, exhaled gases. And again, this is the self-inflation bag you have, and this is the oxygen reservoir, and this is the pressure control system as I told you, to leak out the excess pressure or take in atmospheric air in case of emergency scenario. So this is how a valve works generally. So whenever you compress it, it's a one-way valve. It goes and occludes the expiratory ports, and make sure when you are compressing the self-inflation bag, the air only moves towards the patient. Similarly, when the patient is doing expiration, when the patient is exhaling gases, it will push the valve to the other side so that the gases doesn't move into the self-inflation bag again, so that it goes out through the expiration ports. Clear? So that's the idea. So this is how a valve works. So anyway, this is the principle of how an Ambu works. Let us see some of the parts now in real-time Ambu and how to connect a PEEP valve. So this is the oxygen nipple. So let me draw in green. So this is the oxygen nipple. So where you will connect the oxygen port, and this is the reservoir port. Reservoir port, where the reservoir will be connected. And what are these two? These are the safety valves. I told you, there will be safety valves sometimes in the Ambu itself, in the device itself. So these are the safety valves. Fine. And you can see the outlet area. Outlet area will be called as fish mouth valve. That outlet valve, especially when you are using in a Laerdal valve. So Ambu may or may not have a fish mouth valve, but Laerdal devices will have a fish mouth valve only. But generally we call it as a fish mouth valve. What do you mean by fish mouth valve? When the bag is inflated, you can see the valve will be closed. When the bag is deflated, that is, deflated means when you are compressing the bag, you can see the opening is like a fish mouth and pushes the gas outside. So this is an outlet fish mouth valve. That's an expiratory valve or a patient valve. And little bit turning the outlet area and showing it how it will look like is you can see the pop-off valve. I don't know how much you can notice, but you can see it here. It is mentioned as 60. I don't know whether you can see it properly or not. It's mentioned as 60 here. It's a 60 centimeter pop-off valve, which means when the pressure exceeds 60 centimeters of water, this pop-off valve will open. And you can also note this is the expiratory port. You can see there is small opening is there here. So this is an expiratory port from which the gases come out, the exhaled gases. This is the expiratory port for the patient. So which means patient will be here, the mask will be here, and the patient exhales, the gases will come out through the expiratory port rather than entering into the self-inflation bag again. Clear? And this is another angle showing the inlet valve. So this is the oxygen nipple here, and this is the reservoir port, and where you have the reservoir connected. And you can see this is safety valve again. It might open in times of emergency. It can push. Similarly, you have another safety valve also which can take the gas from the atmosphere in case of emergency, malfunctioning of the oxygen flow. So this is the classic AMBU. This is the AMBU. AMBU will usually contain this plastic cover like reservoir only. They won't have a proper reservoir. They'll have a plastic cover like reservoir only. And AMBU often will contain expiratory port here, something different. So the expired gas will come out like this only in AMBU. The patient exhaled gas will be coming out through this port only. This is the expiratory port. Similarly, the compressed gases, which means whenever you compress the AMBU, the gases will flow in this direction and come through the mask into the patient. So that's how it works. And this is the pop-off valve here. This is the pop-off valve. Clear? Usually the PEEP valve will be attached here, because I told you the PEEP valve will be attached in places where you have the exhalation port. That's how you attach. In AMBU, attachment of a PEEP valve is very simple because you have a very good mechanism over here. So you just remove that area and you just put a PEEP valve over there. It's very simple. But Laerdal devices have some problem. To attach a PEEP valve, you need a separate thing called a diverter. Let me show that. How to attach a PEEP valve to the Laerdal device, because this is what is commonly available in many of the hospitals in the country. That's why I want to show this. Initially, you need to have something called a diverter. Remember, this is the expiratory area, and this is the expiratory port. Remember, this is the expiratory port, and this is the outlet area. And this is the outlet. What is holding is the outlet area, and this will come towards the patient end. Fine. So this is the diverter. You need a diverter for that. So I'll show you how a diverter will look like. This is how a diverter will look like. This is a diverter, and you have to attach this diverter to the outlet area. Attach the diverter. So once this diverter is attached, now in this area you can attach the PEEP valve. In this area you can attach the PEEP valve. So this is the PEEP valve. You can attach the PEEP valve now, and this you can connect to the patient end. So when he is exhaling, this PEEP valve will capture some of the pressure, and it will generate a positive and expiratory pressure. So that's it. So this is how a PEEP valve looks like in zoomed configuration. So this is how a PEEP valve looks like. You can see 10, 15, 20, 5 also will be there, so that you can set at different levels of positive and expiratory pressure while giving a bag valve mask ventilation itself. So these are some very, very important points about the self-inflating bags. And this is the final picture I'm going to show. So this is the viral filter. This is the viral filter here, so which is important in the current season as well. This has to be known. This yellow color thing, what I've shown, is the viral filter there. And you can see this is the pop-off valve here. This is a different device. I think this is a Mayo device. I mean, arrangement mechanism is the same, but where they are located might be different. So this is the pop-off valve in Mayo device, and this is the outlet area. This is the outlet area, and this is the expiratory valve, and this is the PEEP valve that is attached. This is the PEEP valve that is attached, and you have a diverter here, and you have viral filter also. This is the mask. So this is a simple arrangement. So I want to show you the viral filter. That's why I showed you this image. So you can put the viral filter between the mask and the expiratory port also. Clear? So that it filters the expired air from having the virus. So what is this? This could be a very, very important image-based question in your exam. This is the flow inflating bag. Flow inflating bag. It's a bit complicated, so I'm not going into details of the flow inflating bag. So you have a lot of types of flow inflating bag. With flow inflating bags itself, you can give a PEEP. how the gases are getting filled, it's again a long shot. So, but you need a lot of expertise to use flow inflating bags. Let me tell you the differences between a flow inflating bag and a self-inflating bag. So, I can write self-inflating bag here and flow inflating bag here. So, first, self-inflating bag is easy for a beginner to use, whereas it's very tough, it's very challenging. Self-flow inflating bags, it's not that easy to use because you have to adjust the mask properly, because if you leave the mask fit, the bag will not inflate. So you have to keep the correct mask fit, and you have to know how much tidal volume to give. It's little tough, it's not that easy. So you need some expertise in that. So it needs some challenging like understanding about how a flow inflating bag works. Next, it self-inflates. Even if no oxygen is connected, just room air is enough, it just self-inflates automatically. It never self-inflates. You need free-flowing oxygen. Free-flowing oxygen to inflate the bag. Plus, at the same time, you need a tight seal of the mask. So then only you will get the good inflation. Otherwise, you will not get a good inflation. Okay. So works even with a poor mask fit. Yes. Because it's self-inflating. It doesn't work with a poor mask fit. It requires a good mask fit. I told you already. Good tight seal is very, very important. Next, FiO2 40 to 45% without reservoir and practically 100% with reservoir. Here always 100% because you can work only with oxygen. There is no room air here. Only free flowing oxygen can inflate the bag. That's it. So it's always 100% FiO2. There's no doubt about that. That's one big advantage of flow inflating bags. And you can't feel lung complaints here. Cannot feel lung complaints. Actually, you can feel here. You can feel that when you're pressing itself, you can see the resistance. Sometimes you can feel the airflow resistance. You can feel the lung complaints. It's very good actually, beautiful flow inflating bags. Have you ever used that? It will be very easy, especially when you have done an ARDS patient, you will understand how difficult it is. Anyway, so you can feel the lung complaints. Next, similarly, it cannot feel the patient's respiratory effort, rate, tidal volume. All these things are very difficult to feel in a self-inflating bag, where you can feel actually all these things. When a patient inspires spontaneously, this bag will collapse automatically if the mask is of a tight fit. So it does, yes, it can feel the respiratory effort of the patient, it can feel the rate of the respiration, it can feel the tidal volume also. Difficult to deliver smaller tidal volumes because you don't know how much to press, how much to give, very difficult. So difficult to deliver small tidal volumes, very challenging. Easy to deliver smaller tidal volumes also. So these are some of the differences between a self-inflating bag and a flow inflating bag. Remember, this needs an expert flow inflating bag. Definitely, we don't give it to a beginner, or you don't give it to a staff nurse or a paramedic usually. You need an expert for this. Okay. We move on to the miscellaneous devices. And as I told you, the next thing we're going to see is the Venturi device. Remember, it depends on the valves. That's all. The Venturi means valves. These valves are the ones that are the key here. And again, as I told you, this will contain a corrugated tubing like this. Whenever you see a corrugated tubing, you can understand that this is a high flow device. This is definitely not a low flow device. Everything is a high flow device. But even though these Venturi valves and Venturi devices are getting obsolete, we have other high flow devices which can deliver even more FiO2 and more accurately and with a good flow. Still, it's important to understand about the Venturi principle. So what is Venturi principle and how this affects the flow and FiO2? How can they deliver a fixed and accurate amount of FiO2? Let us see. Let us take a flowing area, and intentionally you are constricting that area. When you constrict that area and you leave an opening and again open that area, so what will happen here? So this is a beautiful mechanism. So what happens whenever the gas is flowing through this area, they'll go at a particular velocity. Whenever they cross an orifice like this, they start passing very fast. That's very, very important. I told you, this is simple Venturi principle. So they will definitely create high velocity jets whenever you constrict the orifice. As per Bernoulli effect, definitely there should be low pressure, obviously. And you have created an orifice there. So this high pressure jet oxygen that is passing, so here we are talking about the oxygen here that is flowing, this high velocity oxygen creating this low pressure jet, low pressure area in this zone is going to trap atmospheric air. It's going to suck in the atmospheric air, and this is the Venturi effect. So now you can see the oxygen flows along with the atmospheric air also flows. That is entrained. This is called atmospheric air entrainment, and that is also going to flow. And finally, the patient is going to get a mixture of oxygen and the atmospheric air together, and there will be extremely high flows that is reaching the patient end. But sir, you told in the nasal cannula also told the same thing, that oxygen is getting, atmospheric gas is diluting, and in face mask also you told atmospheric air is diluting the oxygen. So what is the difference between Venturi and that then? Very simple. In face mask and nasal cannula, it is not calculatable. It is not quantifiable. But this Venturi effect is mathematically quantifiable. You can calculate how much flow of oxygen, how much orifice diameter, and how much air entrainment, and how much final flow to the patient, how much mixing will happen, and how much will be the FiO2 delivered. Everything can be calculated. That is why these Venturi masks and Venturi devices can deliver accurate FiO2 with accurate flow, which means they have a fixed flow with a fixed FiO2. At that FiO2, that will be the flow. You can calculate them mathematically, and that's a big advantage. In face mask, nasal cannula and all, the atmospheric air is diluting, but we don't know what is reaching the patient ultimately. But here, we clearly know what the patient is going to get. And it's a high flow device. Let us see how it's a high flow. For this, let me load a table that will help you to understand better. You can see this table here. So at a fixed FiO2, which means, that is what that valves are delivering. So you have seen different colored valves, isn't it? So all are delivering a fixed FiO2. I think blue is the least, 24%, I guess. Then white is 28 to 32%, somewhere around. But you don't have a green here. Green is usually 60%. That's the maximum. In India, that's the maximum that's available. 60% is what the green is. But blue, I think it's 24%. White is 28 or 32. But anyway, the color coding will differ according to different companies. So don't worry much about the color coding. The green usually always is fixed 60%. Clear? So this is the Venturi valve. And these are the valves. You can see the orifice is narrow, isn't it? That's the one that creates the Venturi effect, and you have the opening here. After the orifice, you create an opening also, so that through this only the atmospheric air will be entrained, so that you will be resulting in this Venturi effect. So this is the valve, simple valve, nothing big, creates this effect. And you can see for this 24% oxygen to be reached, the flow is fixed, that is 104. And that's how they will create that orifice, and that's how they will design that valve. And here the entrainment ratio, if you see, it's 1:25, and the oxygen flow 4 liters is enough. 4 liters of oxygen, but for every 1 liter of oxygen, 25 liters of atmospheric air is entrained, which means for 4 liters of oxygen, 100 liters of atmospheric air will be entrained. So that is the reason final flow that the patient is getting is 104 liters. Seriously high flows, isn't it? 104 liters. How much? Seriously high flows, 104 liters. So definitely it's a high flow days. Even 19, it's a high flow only. So it's anything more than 15, I told you it's high flow, comparatively, at least practically speaking. But one thing you can note, as you move down, as you come down and increase the FiO2, let me put an arrow, as you come down like this, and if you increase the FiO2, you can see at 70%, you can see the oxygen flow is, when you increase FiO2, the oxygen flows are increasing. No doubt about that. But the entrainment ratios are decreasing, and the flow to the patient is decreasing. Still 19 is a high flow only, no doubt about that. But compared to 104, 19 is less. So which means what I'm trying to tell is, when you want a more FiO2, you need more oxygen, right? You need more oxygen means your orifice will become bigger. Then only more oxygen flow can happen. When the orifice gets bigger, the velocity drop, the velocity increase. will be less. I mean, velocity is increasing, right? So that high velocity only is producing low pressure, that only sucking in atmospheric air. So when the orifice is bigger means the velocity change will be less. So the pressure change also will be less. That is why the atmospheric air entrainment is also less. Simple physics. That's also, that's why the total flow to the patient is also less. So this is one thing that you have to understand. As you increase the FiO2, the oxygen flow will increase, but the entrainment ratio will decrease and the atmospheric air trapping will decrease and the dilution from the atmospheric air should and will decrease, and accordingly the total flow to the patient will decrease as well. So this is a simple Venturi principle. No need to mug up the table. Just understand the principle of what I am trying to tell. Only in COPD patients it's of useful because we have to know exactly what FiO2 we are delivering to them. Apart from that, this Venturi principle doesn't have much application right now. It's getting slowly obsolete. Then these are the tracheal masks. I generally call it as a trach masks. So it's like a face mask for the tracheostomy patient. So you can see this image is very important. So this is a tracheostomy patient with the tracheal mask attached to them. So this is the oxygen that is coming. Clear? So this is how a tracheal mask look like. Probably an image based question, could be. So please note it down. Then you have a T-piece. Remember, this is different from a T-piece resuscitator that you use in a pediatric resuscitation. Pediatric resuscitation usually it is made of either bag valve mask ventilation or a flow inflating bag valve mask ventilation, or referred to as a T-piece resuscitator. This is something different. Here what T-piece I'm talking is about the intubation weaning. So whenever you want to wean the patient, weaning of intubated patient or weaning from a ventilator. This is very, very helpful in adults. At the same time, for transport, for short-term transport, this is very, very useful. Whenever you want to take a CT or MRI for the patient who is already intubated and getting ventilation, but spontaneous breathing is a very important. They should have spontaneous breathing. So then only you can wean from ventilator, isn't it? Similarly, a spontaneously breathing patient but intubated, but want to transport to CT or MRI, T-piece is a good option. So a lot of areas you can use a T-piece. Clear? So this is how a T-piece looks like. So from here only the oxygen flow happens. Usually they will have a very, very high flow. Sometimes even we release at flush flows at 70, 80 liters. Flush oxygen flow will be there. So they will be containing at a very, very high flow they will be coming. And remember, this will be the patient end. This will be the patient end. So while during inspiration, the patient will take in the oxygen, but at the same time, when the patient is exhaling carbon dioxide, so let me draw in red probably. So exhaling carbon dioxide. So this time you might argue that this might reach the, this might stay in the tube and they might result in breathing of carbon dioxide. But this doesn't happen because of such high flows that are moving through the tube. This carbon dioxide will be immediately washed out. Yes, the gas will be wasted. So a lot of oxygen will be going here all the time. So that's why whenever you connect to T-piece, there will be a sound will be there all the time. So, but there will be no rebreathing because the moment the patient exhales, all the carbon dioxide will be washed out by these high flows. So that this is a very good thing. So simple arrangement, very, very simple arrangement. So simple way of physics. So you can see here. So this is the area where oxygen comes from, and from this end there will be a very high flow that is moving here. The patient will be taking oxygen through this, and whatever exhaled gas the patient is releasing, it will be flushed out along with the high flows and will be moving out. This high flows will flush the carbon dioxide or exhaled gas out. So this is a simple connection, very, very simple connection. TP is very effective for weaning from the ventilator or a spontaneous breathing patient who is intubated. For transport patients, transport situations and all, we use this T-piece only. This is a T-piece ventilator. Then we are moving on to some of the special devices. That is hyperbaric oxygen therapy, HBOT. So this is a hyperbaric chamber. This could be a potential question in the exam. So they give a chamber like this and they can ask you what is this? This is a hyperbaric chamber. So why you need hyperbaric oxygen? So a lot of applications are coming up. Again, you go to US citizen and ask what is hyperbaric chamber. Everyone would have gone for hyperbaric chamber at least once. Just they believe that hyperbaric chamber improves their health, excess oxygen in the body. So even normal people also go to this hyperbaric chamber and become a lot commercial in the United States. But anyway, so there are some medical applications for hyperbaric oxygen therapy. So what is basically the hyperbaric oxygen therapy? It is nothing but you are delivering 100% oxygen, at least near 100%, at least near 100% oxygen at 2.5 to 3 atmospheric pressures. At 2.5 to 3 atmosphere, which means you are not only giving 100% oxygen, but at high pressures you are giving. So you know what's going to happen. So when you are giving 100% oxygen at high atmospheric pressures, your amount of gas, oxygen that is dissolved in the blood will increase. That's the idea. For example, let us assume, this principle is what we refer to as Henry's law. If you don't remember Henry's law, please go back to the physiology section and look at what is Henry's law I have told. And this is the basic reason behind getting a disease called Kaizen disease. That's what otherwise referred to as a decompression sickness, isn't it? So what Henry's law tells, the amount of dissolved gas in any solution is directly proportional to the pressure applied, pressure of that particular gas. Clear? So this is what the basic idea is. So which means here we are increasing the O2 pressure dramatically. The partial pressure of O2 is increased dramatically, oxygen pressure, which means obviously since it's proportionate, the amount of O2 dissolved also will be increasing in the blood. Amount of O2 dissolved in blood will definitely increase. This is the basic Henry's law. This applies to nitrogen, this applies to carbon dioxide, everything. This is Henry's law. But here we are giving 100% oxygen, so oxygen will dissolve too much. So let us assume what is the normal distribution of oxygen in the blood. We are talking about content of oxygen, how it is distributed. Remember, oxygen content in the blood distributed into two areas. One is oxygen that is bound to hemoglobin, and second is oxygen that is dissolved in the blood. Oxygen that is bound to hemoglobin is 98 to 99%. Dissolved in the blood is only 2%. That is PaO2, partial pressure of arterial oxygen. But suppose if you are giving, what is the normal dissolved oxygen? So at atmospheric air, at atmospheric pressure and room air, you will be having a FiO2 of 21% at 1 atmosphere, which means room air will contain 1 atmosphere at sea level. So your dissolved oxygen will be 0.3 ml per deciliter. So this is the dissolved oxygen. So normally arteries will contain approximately 19 to 20 ml per deciliter, which is so much higher than what you find in the dissolved, what you see, what the dissolved oxygen is. Suppose if you are giving 100% oxygen, that is FiO2 becomes 100 now. But at 1 atmosphere, what will be the dissolved oxygen? Dissolved oxygen now it will increase to 1.5 ml per deciliter, 5 times higher. 21%, now 100%, so 5 times higher, so it becomes 1.5. Now you are delivering 100% of oxygen, that is FiO2 at 100%, but at 3 atmospheres at hyperbaric pressure. So now the dissolved oxygen, according to Henry's law, because the pressure is increasing, definitely dissolved oxygen should increase. Now it becomes 6 ml per deciliter according to the calculation. So you are increasing the content of O2 in the blood overall. So where you can use this principle to help you in which disease? Very simple. Whenever you have a carbon monoxide poisoning, what happens? Now what about the oxygen content in a carbon monoxide poisoning patient? The oxygen content in carbon monoxide poisoning patient will reduce. Why? Because now the hemoglobin should carry 98%. Now it's not going to carry that much. The oxygen carrying capacity of the hemoglobin is going to reduce because it's now bound to carbon monoxide. So what will happen to the dissolved? Dissolved oxygen will remain the same. I told you carbon monoxide poisoning doesn't affect the dissolved oxygen. So PaO2 will be usually normal only. Clear? So there will be no problem in the dissolved oxygen. You can go back to the carbon monoxide poisoning chapter and see in the hematology. There will be no change in the dissolved oxygen. It will be the same. So, but the net content of the oxygen in the blood will decrease, and that is the reason the tissues go for hypoxia, and that's the reason why they die of carbon monoxide poisoning. So what I am trying to do by giving hyperbaric oxygen therapy is, so when I am giving a hyperbaric oxygen therapy, what I am trying to do? I am increasing the O2 pressures in the blood, which means I am increasing the dissolved oxygen too much. Since I'm increasing the dissolved oxygen, this decline in the oxygen carrying capacity of the hemoglobin can be compensated by the increase in the dissolved oxygen, and the patient will not go for hypoxia, the patient will survive. That is the basic first principle of giving HBOT in a carbon monoxide poisoning. Clear? Selected indications are there. I'm not talking about that. We have discussed already in hematology, but this is how HBOT therapy works in carbon monoxide poisoning. At the same time, remember, HBOT therapy reduces the half-life of carbon monoxide. For example, 4 to 6, not 1 T-half, 4 to 6 T-halves of carboxyhemoglobin is 40 to 80 minutes. With just 100% oxygen. If you just give 100% oxygen at 1 atmosphere, 40 to 80 minutes will be the 4 to 6 elimination half-life approximately. That is 4 to 6 T-halves will be usually elimination half-life of carboxyhemoglobin molecule. But if you give 100% oxygen at 3 atmospheres, now the same 4 to 6 half-life of carboxyhemoglobin will become 10 to 30 minutes, which means you are reducing the half-life of carboxyhemoglobin drastically. Elimination half-life of carboxyhemoglobin drastically you are reducing. So which means the recovery will be faster. So these are the advantages of using hyperbaric oxygen therapy in carbon monoxide poisoning. Similarly, I told you, since carbon monoxide, this hyperbaric oxygen therapy is increasing the dissolved oxygen, this can be useful in multiple areas. For example, in anemia. Remember, carboxyhemoglobin is also a case of anemia. In severe anemia, profound anemias, you can use hyperbaric oxygen therapy, because even though the hemoglobin is low, your content of the oxygen in the blood will increase by increasing the dissolved oxygen. So clear? So you are counteracting or counterbalancing the decline in the hemoglobin and the total decrease in the oxygen carrying capacity by increasing the dissolved oxygen. You are maintaining the net oxygen content in the blood, and the oxygen delivery to the tissues will be okay. So that's why in profound anemia you can use, but even though there is no standard indications for that, and you can use in acute and chronic ischemias. Same principle. Acute and chronic ischemias, where you are increasing the oxygen content in the blood, means the ischemic tissues will be perfused properly. So in acute and chronic ischemias, you can use this hyperbaric oxygen therapy. Similarly, you might be asking how hyperbaric oxygen therapy is helpful in Caisson disease. Caisson disease. Caisson disease is nothing but your decompression sickness. What is the problem in decompression sickness? Because you form nitrogen bubbles. This is small vessels which is dividing into multiple small vasculature, let us assume. And you form nitrogen bubbles in the blood. When you form these nitrogen bubbles in the blood, these nitrogen bubbles will go and occlude the small vessels, resulting in ischemia. And fatal infarcts will happen. And this is the reason why you get Caisson disease and death, decompression sickness. The problem is this nitrogen bubbles only, bubbles of nitrogen. Due to sudden movement of the person from deep sea to the surface, because of sudden drop in the pressure. How hyperbaric oxygen therapy will be helpful? Remember, hyperbaric oxygen therapy will create oxygen bubbles. Obviously, they will create oxygen bubbles. If they create oxygen bubbles like this, these oxygen bubbles will compress the size of the, one mechanism is they will compress the size of the nitrogen bubbles. For example, if you take this is the size of the oxygen bubble and this is the size of the nitrogen bubble, this oxygen bubble will physically compress the size of the nitrogen bubble and they will reduce the size to 2/3. 2/3 reduction of the size of the nitrogen bubble will be there, which means now the nitrogen bubble can easily pass through the smaller bubbles. Smaller bubbles can easily pass through the microvasculature without any occlusion. Point number 1. Now you might ask me, what about this oxygen bubble that is passing now? So this bigger oxygen bubbles can actually can occlude, isn't it? This microvasculature, but doesn't, because this oxygen will be rapidly metabolized by the tissues. Nitrogen cannot be taken in. Simple. So oxygen is metabolized, nitrogen is not. That's why these bubbles, if it's bigger, is occluding the capillaries and microcirculation. So that's how it works. So first mechanism is by compressing the size of the nitrogen bubbles, it might work. Clear? So to less than to reduces to more than 2/3 of its original size. Second mechanism how it can work is the oxygen bubbles can take the nitrogen bubbles within them. So once the oxygen bubbles take in the nitrogen bubbles, this will be utilized by the cell. They will take the oxygen as such, and along with it they will take nitrogen also, and both will be metabolized. Clear? Very simple. And nitrogen is very easy to metabolize. I mean, in the sense like they don't take it actively, but along with oxygen, if they take it, nitrogen is easy to metabolize inside the cell because they will make amino acids, they do something with the nitrogen. So this is one more mechanism how this hyperbaric oxygen therapy works in Caisson disease, decompression sickness. So now you can tell about the applications, and it has a lot of other effects also. For example, it can produce wound healing. It can accelerate the wound healing. It can reduce the fibrosis. So many applications are, so many mechanisms are there. But what are the uses of this hyperbaric oxygen therapy? Uses wise, number one, it can be used in carbon monoxide poisoning and cyanide poisoning by mechanisms which I explained already, by increasing the content of the oxygen in the blood. They prevent hypoxia of the tissues. Second, in Caisson disease, decompression sickness, we have told already. Third is air embolism, similar mechanism, like how it worked for decompression sickness. There are nitrogen bubbles, here air bubbles, that's all. Number 4, crush injuries. Crush injuries, compartmental syndrome, these are acute ischemia. So HBOT is proven to be beneficial. Then infections, certain infections, especially clostridial myonecrosis, like gas gangrene, clostridial myonecrosis. Then radiation related injury, definitely, yes. Then in conditions where you have non-healing ulcers, then infected skin grafts, non-healing infected skin grafts, and non-healing wounds. So in all these areas, HBOT is proven to be beneficial. These are some of the important uses of hyperbaric oxygen therapy. So what are the complications? Complications are very few. You don't get that many complications with hyperbaric oxygen therapy. What are the complications? Complications wise, you can result in barotrauma. This could be an exam question. If they ask you what is the most common complication, it's the barotrauma only. But which site, if they ask you, most commonly it's in the middle ear. Middle ear barotrauma, that too with repeated therapies only. One therapy will not cause. Repeated therapies may result in middle ear barotrauma, followed by second most complication is sinus barotrauma. But remember, pulmonary barotrauma causing pneumothorax is very, very rare. You don't get it. But first is middle ear barotrauma, second is sinus barotrauma. These are the two most common complications. Number 2, it can cause a myopia because of oxygen toxicity, but reversible. It's proven to be reversible. It's not irreversible. It's a reversible myopia for some time. So, or you can result in oxygen toxicity like cough, chest tightness, very rare. Again, these are very, very, very rare. And again, some people can have neurological toxicity, again very rare, which can result in seizures, very, very rare again. So barotrauma is the commonest. If you know that much, that's enough, because you are giving high pressure oxygen. So that high pressure itself can induce a barotrauma. Usually middle ear, sinus, second. Pulmonary is very rare. Pneumothorax is very rare. Clear? Now the final topic in this long journey will be on the long-term oxygen therapy. LTOT, very important topic in pulmonology. You know, it can be used in any chronic lung disease. So you have to know about the oxygen delivery to these patients who receive LTOT. Remember, first of all, what are the indications for LTOT? Even though I discussed in COPD section, but you have to know. LTOT is something you can use in any chronic lung disease, not only in COPD. Even IPF, it's useful. So there are some indications for that. What are the indications? So first, you have to do resting saturation. At the same time, it should be done in the room air. Whatever values I'm going to tell should be at rest and it should be at the room air. This is the first principle. Rule number 1 is if PaO2 is less than or equal to 55 millimeters of mercury, or if SpO2 is less than 88%. So this is indication number 1. Second indication, either if PaO2 is less than or equal to 59 millimeters of mercury, or SpO2 is less than or equal to 89%, but the patient here should have either one of carpulmonal or polycythemia. Any one. So this is a time-tested thing. If you give long-term oxygen therapy to these patients, definitely they show lesser mortality and improved survival. And LTOT should be done at least more than 15 hours per day. This is mandatory. And even if you give 24 hours per day, I don't have any problem. But it should be at least minimum more than 15 hours per day. And generally, we give only low-flow oxygen. We don't give high-flow oxygen because, especially in patients like COPD, they go for hypercarbia and carbon dioxide retention. So with high-flow oxygen, so we generally prefer giving a low-flow oxygen. One of the best ways to give this low-flow oxygen is a nasal cannula. Through nasal cannula, we give. But the problem with the nasal cannula, it's wasting a lot of oxygen. So that's why we need to know about the oxygen conserving devices also. But at the same time, you have to know what is the amount of oxygen flow in the nasal cannula I have to start with. Remember, to start with, I will take the starting PaO2 and I will tell what is the FiO2 I have to give and what will be the setting in the nasal cannula. Simple. So if the starting PaO2 is 50, my FiO2 will be 24%, and you know very well 1 liter in the nasal cannula is going to deliver approximately 24% FiO2. Starting PaO2 is 45, 28%, 2 liters. Starting PaO2 40, 32%, 3 liters. Starting PaO2 35, FiO2 35%, and 4 liters in the nasal cannula. Clear? So these are the various settings in the nasal cannula to start with. So this is how we start with the LTOT, long-term oxygen therapy. Remember, I told you already, the only two things that improve survival in COPD patients is LTOT and smoking cessation. Where smoking cessation comes the first always, LTOT is the second. But LTOT can be used in other chronic lung diseases also. Clear? Long-term oxygen therapy. So now, since I told you that this nasal cannula is going to waste a lot of oxygen, we have to look out on this oxygen conserving devices, which means it's the patient who's going to ultimately spend on oxygen. It's not a cheap drug as well. It's going to be costly, so you have to look out for the oxygen conserving devices because it's a long-term therapy. That's why we have this kind of transtracheal catheters. Transtracheal catheters. It's very good actually. Advantages because you are reducing the dead space. From here, the oxygen has to go all the way. So that's not needed here. From here itself, if the oxygen goes, the amount of oxygen that they need is very less. So which means they are reducing the dead space. That's the idea. Transtracheal catheter. So you can see one catheter is inserted into it. So this will deliver oxygen directly into the trachea. So transtracheal catheters, they reduce the dead space and that's how they work. And cosmetically excellent. The patient will accept. Very good. Cosmetically excellent. Patient can hide them with the collars, and if they put the collar button, nothing will be visible out. So it's cosmetically very good as well. But some complications are there, like they can go for mucus plugging, and they can go for bleeding, and they can even go for malposition. But they require daily cleaning. Again, patients are comfortable with that. They need daily cleaning, but they're okay with that. So these are some of the complications of transtracheal catheters. Efficiency is again very good. High flow rates can be achieved sometimes at even 16 liters per minute in selected patients, not in COPD patients. But transtracheal catheters are very good options for conserving oxygen. Clear. So second one, we have this reservoir nasal cannulas or nasal cannulas with reservoir. You can call it in any way. Again, this was first invented by a company called Oxymizer, and the name is Oxymizer only. So there are many configurations of Oxymizer. You can see a reservoir here. This is a reservoir where you have this mustache configuration of reservoirs also, and you have this kind of pendant configuration of reservoirs also. These are excellent, really. They don't have any problem at all. They store good amount of oxygen and they reduce the oxygen necessity. For example, if you see, this is the continuous flow versus reservoir cannula. This is an ordinary nasal cannula versus reservoir cannula. You can see to achieve a saturation of 94% almost, you need just 2 liters of oxygen in a reservoir cannula. But for achieving the same amount of oxygen flow, saturation in the patient, you need almost 4 liters of continuous flow of oxygen through the nasal cannula, which means clearly the oxygen requirement is half with the help of a reservoir cannula. So definitely oxygen is conserved here. There's no doubt about that, which is good for patients' economic status. But the problem is cosmetics. They are very ugly looking and patients don't like it at all. Cosmetically, it is obtrusive and disfiguring. So they don't like it at all. So comfortable, it is comfortable. Comfort wise, it's not a problem at all. Comfortable, it is adequate and there is no complications at all. There's absolutely no complications like transtracheal catheters and all. Cosmetic is the only problem for many of the patients. You can achieve high flows also in this. Efficiency is also very good. Almost 2:1 to 4:1. I told you. In the sense like they reduce, I told you sometime back, they reduce the oxygen requirement by half. That's why I told you 2:1 to 4:1 efficiency compared to the nasal cannula. Transtracheal catheters have an efficiency of 2:1 to 3:1, very similar to that of reservoir cannulas only. So whichever patient is comfortable with, you can ask them to get that. Clear? These are called as pulse oxygen or pulse oxygen delivering devices, pulse oxygen delivery, or otherwise referred to as a demand pulse. So how this works? So here they are going to conserve oxygen extremely good. The conserving efficiency will be 3.1 to 7.1. Almost 3.1 to 7.1 is the conserving efficiency here. But remember, the physiology behind how this conserving devices will work. When the pulse should be delivered is the key. Further, I am going to the same old diagram which we discussed. One diagram in end inspiration, end expiration, and another diagram in end inspiration. You know very well at the end of expiration, the dead space and the alveoli is going to contain CO2 rich gas. And this is going to be oxygen poor gas. And this is the dead space. This is the dead space, which is approximately equal to 150 ml. And now when the patient is inhaling, so I can divide the air column into 350 ml and 150 ml. So the initial 350 ml and the later 150 ml. So this is the first thing the patient will be inhaling, that first 350 ml that is passing through the respiratory tract. And remember, that is the one that is going to enter. And the initial 350 ml is the one that is going to fill up the alveoli and they are going to participate in the gas exchange. This initial 350 ml only. That first portion that they inhale, the 350 ml is the one that's going to participate in the gas exchange. The later 150 ml, the second 150 ml, later 150 ml is going to contribute to the dead space only. Which means that gas is useless. Which means why you want to give continuous oxygen? If you deliver a pulse during the initial phase of inspiration, that itself is enough, isn't it? If you just deliver a pulse during initial phase of inspiration, that gas, that itself is enough. It's going to help in the gas exchange. So you did not deliver continuous oxygen at all. During expiration, why you need continuous flow of oxygen? Similarly, during inspiration itself, why you need continuous flow of oxygen in the later part of inspiration? But again, it's unevenly distributed. You have to understand, it's not like 350 ml. And again, it's an advantage. That's what these devices are going to use. This initial air that you are inhaling, so that is the one that's going to enter the alveoli. Clear? Ultimately. The later 150 ml I am inhaling is not going to enter the alveoli. It's going to saturate the dead space only, which is useless. And again, if you think very carefully, the initial part of the breathing inspiration is faster. And the later part of breathing is slow, which means that 350 ml enters fast, enters the lungs fast, because it's initial phase of inspiration. The later 150 ml enters very slowly, which means that initial period, since it's entering very fast, if you give like a pulse oxygen in the initial phase itself, immediately when the inspiration starts, you will achieve a good oxygenation, which means that is the gas that's going to cause a gas exchange in the alveoli. So that is the principle how this pulse oxygen delivery devices or this demand pulse devices are going to work. And remember, you have to deliver as soon as the inspiration starts. The more and more you deliver later pulse, there is a lot of chances that the gas will go for a dead space. The more early you deliver, they will reach alveoli faster, so which will improve the gas exchange. I mean, that is going to be the most important. So clearly this graph again shows you can see the more and more delay you do. For example, if it's 164 millisecond delay from the beginning of inspiration, means your saturation is this much only. But if you are delivering pre-inspiration or just 1 millisecond immediately after starting the inspiration, your oxygen saturation will be very high, which means it is best to give the pulse of oxygen as early as possible. And these are excellent conserving devices. I told you their conservation ranges from 3:1 to 7:1 almost. But one problem is each and every device has a variable oxygen delivery. There is no consistency among these device manufacturers. That's one problem with them. For example, we have in India very commonly we use this ePod device. We have Helios, we have then Respironics. So many devices are coming. These are brand names, but everything as having variable oxygen delivery. So, but anyway, this pulsed oxygen delivery devices, if they want to use, yes, well and good. They are little costly, but still very good conserving devices, oxygen conservation, because they deliver as a pulse. They don't give a continuous oxygen, which is getting wasted. This is a very brilliant mechanism again, how they are going to use this. And the last device I'm going to discuss is on NIOV, that is non-invasive open ventilator devices, where they're going to deliver oxygen pulses, but not so conserving, but they deliver a larger pulses of oxygen, that is around 50 to 250 ml pulses. They do not deliver small pulses at all. And usually they use a occluding like mechanism for the nose to deliver these larger pulses. And again, the both NIOVs as well as this pulse delivery devices are prone for this mechanical failure, which means you need an engineer to correct all these things. The patient may not be even aware of the failure of the device. So they are a little bit more electronic and technical. So that's one complication. Apart from that, they are excellent oxygen conserving systems. Okay, you have discussed about the delivery devices to the patient, but what are the sources of oxygen? This is one traditional green color coded cylinder. You know, this must be oxygen, green color coded. So this is nothing but a compressed gas cylinder, compressed oxygen cylinder, which is usually having compressed gas at a pressure of 2500 psi, even though they can go up to 3000 psi. But the problem with this is they are very heavy, not portable, very difficult to carry around. If a patient is active and mobile, they don't like this. And it has to be fueled and refilled again and again. So they don't like it. So that's why they move on to the liquid oxygen. The advantage of liquid oxygen is the fact that 1 liter of liquid oxygen will expand to 1000 liter of gaseous oxygen. But you need not have any cryogenic temperatures also, because we use a simple principle called Dewar flask. It's a 8th standard, 9th standard level topic, where when you give a thermal insulation in the form of vacuum around a particular thing, if you don't expose them to heat, they don't boil or they don't lose their temperature. So that's the idea. So this is a simple upgradation of a Dewar flask. So use that and maintain the liquid oxygen. Only one problem with this is they might leak oxygen to the surrounding, but that's fine. It's only oxygen, right? So it's not a flammable substance, don't worry. At the same time, it's not going to cause any toxicity by leaking into the atmosphere. So let it get leaked. But still, we have even more better devices right now. These are called as POCs. What are POCs? These are called as portable oxygen concentrators. And this is the hotspot now. This is what many patients like, and they love this device, especially who are active. They just love this portable oxygen concentrators. This device is beautiful, no? Like it just takes the ambient air and separates oxygen from the ambient air and concentrates oxygen and delivers a fixed amount of FiO2 to the patient. So obviously you are going to deliver only an FiO2 of probably 35-40 max. So you're not going to deliver more FiO2. So these devices can do that excellently, portable oxygen concentrators. And remember, these oxygen conserving devices, whatever I have spoken some time back, you can easily mix with these devices. You can mix with these sources, isn't it? The conserving devices, whatever we have seen, you can mix with the sources and you can give it to the patient. For example, this portable oxygen concentrator, itself can be combined with a demand pulse oxygen delivery device, isn't it? So using that also you can, give the oxygen pulse to the patient. So it's not like you cannot combine, you can combine both devices. So this is a source, that's a delivery device. Both are different. Fine. So ultimately delivery will be through the nasal cannula or reservoir nasal cannula or a transtracheal catheter. These are the delivery devices. So secondary, you use some conserving device, and tertiary, you should have a source. Source will come to the conserving device. Conserving device will be delivered through a nasal cannula or a transtracheal catheter. Finally, simple. So this is the final ways how to give a long-term oxygen therapy, and I think we have covered extensively. It's a long journey. Almost, I think I took 2.5 hours for discussing this oxygen delivery devices, but it's worth. Remember, this is a very important topic, and whatever images I've shown you are going to be the future. Please don't forget. With this, we'll wind up with the big topic and we'll move on to the next topic. Thank you.